Ms Kerry.
My lady, good morning. Can I ask, please, that Mr Hancock is sworn?
I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the
the
whole truth,
and nothing but the
and
truth.
nothing but the truth.
Ms Kerry.
Thank you, my lady. Mr Hancock, thank you for returning and for your 10th witness statement to the inquiry. I have a number of questions to ask you now about the response in relation to the adult social care sector. By way of background, though, you were the Secretary of State for Health and Social Care from July 2018 to the 26th of June 2021. Is that correct?
I was, yes.
Your statement, INQ 587746, sets out your background, but it was primarily in areas of finance. Do I take it that you had no professional experience of the adult social care sector before you became the Secretary of State?
Well, that's not quite true, no, because the nature of being a Member of Parliament means that you have professional engagement with the care sector, care homes, domiciliary care, whether registered by the CQC or not. So I had considerable experience on the ground in terms of supporting my local care homes.
I see. But you hadn't acted in the Department of Health and Social Care prior to your appointment as Secretary of State in the role of social care. Is that correct?
No, that's correct. My background was essentially in technology rather than finance.
Before we descend to some of the detail, can I ask you just to stand back and answer this? Going into the pandemic, do you consider that the social care sector was the Cinderella service to the NHS?
Oh, the social care sector was badly in need of and remains badly in need of reform. I wouldn't call it the Cinderella sector, but I know that a lot of people feel that way. I would say that it is badly in need of better support, better governance, better data and information flows. Ultimately, the 1948 settlement that led to the formation of the NHS left social care as the legal responsibility of councils. The policy responsibility nominally resided with me in the Department for Health and Social Care. The funding decisions essentially came from the Treasury and were communicated through the Ministry of Housing and Local Government. Yep. So there was a hodgepodge of accountability that meant that the levers that we had at the centre were weak. And in addition to that, essentially the NHS could command public attention in a way that the care sector found more difficult.
I'm going to come on to the levers or lack thereof in a moment. But in relation to the pre-pandemic state and perhaps reputation and indeed public attention, as you've just alluded to, within the sector, do you consider that domiciliary care was overlooked at the expense of responding to the impact of the pandemic on care homes?
No, I don't think that's true at all. I think that domiciliary care is incredibly important. And indeed, when we talk about the care sector, we are primarily talking about domiciliary care simply in terms of the numbers of people who are in receipt of that care. That was very much at the front of my mind in terms of how I thought about the care sector. And of course, often when the care sector is used as a shorthand, people often don't think enough about care for those who are of working age, as opposed to those who are frail essentially because of old age.
All right. So from your perspective, not only was it important, but it was at the front of your mind when you were making decisions in relation to the adult social care sector.
Yes. Now, sometimes decisions were different for the two sectors because the circumstances were different, but that was taken into account. Yeah.
Right. And can I ask you the same question? Were the millions of unpaid carers overlooked, do you consider, at the expense of domiciliary care and the impact on care homes?
Well, they were the millions of unpaid carers were considered. It is much, much harder to get support to unpaid carers by the nature of the care and the fact that there isn't a registration programme in any way. But we tried very hard to do that. For instance, the shielding programme was essentially focused on those who were likely to be the most vulnerable, and their carers were a critical part of the shielding programme. So that's just one example of how unpaid carers were considered, but it was much harder to have a single overall policy for them, if you like.
Now, you a moment ago made reference to the lack of levers
Yes.
there was in relation to adult social care, and you've made clear that it's the department, really, as I understand it, that sets the policy, but it's the local authorities who commission the care that is provided in a simple form. Do you agree?
Oh, absolutely. That is the settlement that's been with us since the foundation of the NHS, because, of course, before 1948, the local authorities were also responsible for health provision. This has a series of consequences. But the other thing I put right into the top of this as an issue is the lack of data and the lack of information. So it's not really just the lack of levers, it's also the lack of information that was a huge problem.
Right. We'll come on to that as well.
Sure.
You said in your statement that the Department of Social Care, in fact, has nominal national responsibility. Why is it in name only?
Because the policy decisions that are taken by the national government with respect to care and policy towards care have to be implemented through local government's contractual arrangements or funding which went through MHCLG, as the department was called at the time, whichever government department is responsible for local authority funding, where essentially the funding was supplied directly to MHCLG and through them to the councils by the Treasury. So the department has policy decision-making, if you like, that has to be cleared across government, but it doesn't then execute that policy. The policy is executed through other arms of the state. This is a recipe for difficulty in decision-making, especially in a crisis.
And so when you say we lack the levers, are you able to help those that are watching who are perhaps not familiar with that term? What did you actually mean by the department lacking levers?
Well, I can give you one example relating to data. We needed to know, as best as we could, for instance, how many people are actually getting tested in care homes once enough tests were available. In order to get data like that and others, we put a requirement on the funding, the extra funding that was given in emergency funding, that funding would only be available to a care home if they made the data available. Yeah. That was an innovation in how we created a lever by giving extra funding and requiring data in return for the funding. But of course, if a care home found it very difficult to get that data back to us, they therefore didn't get the funding. That was a necessary part of the lever. Otherwise, the lever wouldn't have any traction. But that itself is a difficult position to put a care home in, and often some of the care homes with the most challenges are the ones that also don't have that sort of data in-house. So there's an example of action we took to try to create levers. If we simply said from the Department of Health and Social Care, we want data on, for instance, how many tests you're carrying out and what the results of those tests are, then we may well get a good reply from a large chunk of the care homes, but we wouldn't necessarily be able to insist or get all of the care homes or other care providers, domiciliary care, for instance, to follow that requirement.
When did you first realise that the department lacked the levers that you think are necessary?
I knew that before I became Secretary of State.
Right. And are you able to answer this sort of rather global question? What would you recommend the government do in future to ensure that it does have the levers to support care providers
Well,
in the event
I think
of a future pandemic?
I think that there's a whole series of things that need to happen now. In fact, they needed to happen several years ago. You know, we're 3 years into this inquiry, and I think that the situation has got worse, not better, for when the next pandemic hits. I would absolutely have a requirement baked into every contract for care provision that allows for requirements to be put in place by central government that are proportionate and medically recommended, so that in extremis, new requirements that we can't think of now may be able to be put in place. Immediately, there's a series of concrete things that should happen now. For instance, one of the major problems that I'm sure we'll come on to was the lack of isolation facilities within care homes. There should be no care home in the country today that doesn't have isolation facilities. It should be a requirement for the provision of care, because we don't know when the next pandemic will hit, and when it does hit, it will hit fast, like this one did. And our problem was, the central problem with that, the discharge question, which I know we'll come on to, was that there wasn't isolation facilities in every care home. Likewise, every care home should have a legal requirement to have a stock of PPE. Right? We got PPE to care homes, free PPE, pretty quickly in the grand scheme of things, but it was very, very difficult and challenging to do that. There's a whole series of recommendations that we can come to, but the levers question is an extremely good one.
I'm sorry, I'm not followed whether you've answered it, Mr. Hancock.
Okay.
You talked about the contracts between local authorities and care providers, and as you'd appreciate, contracts have to be fairly carefully drawn so that people know whether they're in breach of it or not. And I wasn't quite following what you say should go into such contracts. Are you saying things like you must have isolation facilities and you must have PPE stocks? Is that what you're saying? I wasn't following whether your answer was all together or different factors.
I apologise for not being clear enough. Firstly, I think there are a series of requirements that we could set out now that you might consider for your report that should happen immediately, that we can specify clearly, like isolation facilities, PPE stocks, data on communicable diseases. Personally, I would ban staff movement between care homes in good times as well as in pandemics, because communicable diseases kill people in care homes all of the time. And then, so there's a series of concrete recommendations of policies that can be specified now. But I would also put in place, if you like, an in extremis provision that, subject to clinical advice, further measures could be brought in the event of a pandemic. For instance, visitor restrictions, testing requirements. These are likely to be needed, but we can't be certain they'd be needed, depending on the nature of the next novel pathogen. And therefore, an ability of the centre to say to care homes, this is what is required, would be valuable. But you, of course, have to have a reasonableness consideration, because you would be not specifying concrete action, you'd be specifying future unknown action. But that, in a way, that second part is less important than the things that we know should be happening in care homes right now, like the universal provision of isolation facilities and a PPE stock in every care home.
So from your perspective, Mr. Hancock, do you consider that would require legislation to bring about those changes to contractual requirements, or is that a regulatory matter? Can you help us as to who it would be in the event that we wanted to recommend that there were such changes to contracts?
It's a good question. There'd be a number of different ways to do it. Probably the best would be to take a provision in legislation that such measures could be brought in by regulators. That would be, I think, the normal and the best way to do it.
Thank you. All right. Now, you mentioned data in one of your early answers, and in your statement, you say, I was extremely concerned about the lack of data we had on social care, and essentially you considered some of the data that you had to be inadequate.
Absolutely, either inadequate or non-existent.
Right.
Yeah.
Right. Given that the data was inadequate and you were concerned about it, are you able to tell us what you did to try and improve the data that was available to the Department of Health early on in the pandemic?
Yes. So in the first instance, we asked questions. So we simply asked for the information necessary. And we then brought in more and more sophisticated data requirements, both providing the technology for care homes easily to be able to provide the data that was required, and then, as I mentioned earlier, to tie the provision of high-quality data to the emergency funding, some of the emergency funding, not all of it.
No.
Very important that every care facility got some emergency funding, but to an element of the emergency funding. I mean, that was an innovation because we needed to know as much as possible what was going on. And then I suppose the third element was constructing surveys which weren't mandatory, but that almost every care provider lent into the providing data into.
All right. I'd like to look at just one aspect of the data with you, please. And could we have up on screen INQ 274068 _ page 8? Thank you. Mr. Hancock, this is a WhatsApp exchange between you and Miss Whately, the Minister for Social Care, on the 9th of April. And can we highlight, please, on the screen, thank you, from 2120 down. This is about data in relation to deaths in care homes.
Yeah.
And the Minister says, I'm afraid I've been sent the first proper data on care homes deaths just now, and it's not good. Speaking to Public Health England, the CQC, that's Ros Rawton, who was in the Department of Health and Social Care tomorrow morning about it.
Yeah.
You said, OK. Ms Whately says you're doing a press conference, care home death data may come up. We expect official ONS data on Tuesday will show a big jump in deaths. Also, we now have data on deaths of residents in care homes, but there is some double counting because it includes some people who've died in hospital and non-COVID. It's not that we're not counting, it's that it's complicated. Changes to notifications will give us better data soon. And she says we're investigating how COVID outbreaks are occurring, how it's getting in and getting passed on. PHE has launched research. And at 3:36, you say, thanks, do you have a briefing on the death data? Great. And she says she's seen it and discussed it with Ros. And then it looks like you were probably going to go and do a 5 p.m. conference that evening because there's a break in the messages.
Yeah.
Can you help us, Mr. Hancock, with clearly the death data took some time to become available. If we take March as the start of the pandemic, we're 5 or 6 weeks so in. Do you accept that that type of data was essential earlier on to inform the response alongside data on outbreaks?
March wasn't the start of the pandemic. January was the start of the pandemic.
January it started, but by the time we were entering the phase where we're thinking about lockdowns, the numbers are rising.
Yeah.
Take
we were
March
thinking
as
about
a rough starting point.
Since the pandemic started in January, it is absolutely crucial that a point that is really important to recognise, crucial to recognise, is that we knew from very early on, from January, that the greatest impact of this virus was on older people. We knew that from the deaths internationally.
Yeah.
So that's why this point about it just didn't start in March. I mean,
all right, put that to one side.
Yeah.
Whenever the pandemic started, from your perspective, do you consider that the death data was essential and it would have been better to have had it earlier on?
The answer is yes, but I'm also going to unpack it slightly because there's the point here in Helen's 334 message is really important. There are two problems with the data. One is the quality of data that's being received at the centre. The second is what is actually knowable. Because when people, how shall I put it, working out whether a death was due to COVID-19 or not is not a trivial task clinically. Chris Whitty is more eloquent on this than I'm being. And therefore, working out what was non-COVID, what was COVID, and separating out also, was if there was a care home resident who went into hospital and died, making sure that doesn't double count, that's a sort of tractable administrative challenge. But then there's genuine, deep clinical challenges, which is when somebody who's very frail dies, what they died of is a difficult question. And therefore, there were both tractable and intractable problems with the data. Does that make sense?
Yeah, I understand that. And I think the answer to my question was, yes, you would have rather had it earlier on.
Yeah, of
but there are
course.
various practical reasons why it may not be possible to ascertain in the level of detail what is a death from COVID or a death of COVID. I understand.
Death with COVID. But the question, the answer to your question, would it have been better to have the data earlier? Yes. The real question now for the country now is, will we be in a position to have this sort of data right from the start next time? And I just would also put a note on this, in that all of this discussion, almost all of it, will be with respect to older age people, because this pathogen happened to attack and be more deadly amongst older aged people. But the next pathogen may well be just as deadly with children, and you can see that in the middle of this exchange, actually. You didn't read it out, but it's there. And any lessons that we have for the future need to respect the fact that we don't know who the next pathogen will target. Well, there have been pathogens in the past that have targeted men in their 20s more than any other group. And therefore, we can't, in recommendations and in thinking about being prepared for the future, we can't assume that it will have the same impact on the age range. And therefore, the data question isn't just about older persons' care. It's about care for the most vulnerable in the younger age and of working age, as well as, of course, for older age groups.
When Helen Whately messaged you to say that the care home deaths data was in and it was not good, did you ask for an immediate briefing or ask to see the data, Mr. Hancock?
Yes, it's here in the messages. Do you have a briefing on the deaths data? So yes.
You did have it. All right.
No, I asked for it.
Right. Well, I understand you asked for it, but the question I asked is, did you end up getting it?
Well, I did end up getting briefing, and the briefing got better over time. I mean, you can see it in this exchange. I say, do you have a briefing on deaths data? And Helen says, I've seen it and discussed it with Ros, no formal briefing. That's because the quality of the data, we still had data quality. That will be, I presume, because we still have data quality issues at this point. By around May, we had much better data, and in the second peak, we had what I would now regard as high quality data.
Do you know whether the death data was shared with stakeholders so they could provide support and safeguard residents and staff? If you don't know, please say.
I know that we published it, but I don't know when we started publishing it.
All right. And just, we can take that down, thank you. Just broadening the data issue from deaths data, do you agree that there ought to be a national centralised database which contains relevant data about the care sector?
Yes, I absolutely think that that's vital, and I think that it should include all data on all communicable diseases in care homes, in the care sector more broadly, and care homes of all ages. And it should include that data now in normal times as well as in pandemic times. So, for instance, I would have a, say, weekly requirement for any care facility to report communicable diseases to UXA. Putting that in place would be relatively straightforward, and then would allow a much richer understanding of communicable diseases in care facilities all the time. After all, flu every winter is a killer, and this could be done. This could be done now.
All right. Now, you mentioned that communicable diseases should be reported to the UK HSA. Do you consider that they would be best placed to collate the national centralised database, or should that be run out of the department? Can you help with it?
It absolutely should be UXA. That is their job, is to stop communicable diseases from damaging the population.
Fine. All right. But before we turn perhaps to the initial response to the pandemic, can I just ask you this about engagement with the sector more generally? Did you, as Secretary of State, engage with stakeholders, the National Care Forum, the various care provider alliances, or was that something that you left to the Minister to deal with?
I did to a degree, but largely it was that was a primary task for Helen Whately. And when you say left to the Minister, that rather understates the capability of Helen Whately, who is an absolutely first-rate Minister. And as you'll know from her and my text exchanges, we had an extremely high-quality and professional relationship.
You said you did to a degree. Are you able to help with who you actually engaged with in the sector?
I haven't got it in front of mind. It's all there in the records.
Right. We know that you told us in Module 3 that you visited a hospital during, I think it was January of 2021. Did you undertake any visits to care homes, whether in person or virtually?
Yes.
And are you able to tell us when that was and give us some detail about that visit or visits?
Well, firstly, I visited hospitals many times over the course of the pandemic when it was safe to do so, not just once in 2021.
No, but that was the example you gave us in Module 3, which is why I lighted upon it.
Right.
So just help us with the care homes,
yes.
please, Mr. Hancock.
Yes, I did.
How many did you visit? Tell us what you saw. Tell us how it helped inform your response to the pandemic.
So I visited care facilities both virtually and when it was safe to do so in person. Remember, visiting restrictions were strong during most of this period in order to protect residents. I visited, for instance, in my constituency engagements where I had good relations with many of my local care facilities. I'm very happy to provide a list, but you have the documentation that'll set out when I did those visits. I found it vitally important in a leadership role to listen to what I heard on the ground. For instance, the importance and the gratitude for the free PPE that we supplied was something that was always brought up with me on a visit to a care home after the first peak. That's one of the reasons that informs my recommendation that there should be PPE stocks. You know, when suddenly there was a requirement for PPE, and remember that since most care homes are private facilities, purchasing PPE was a private matter that the government didn't really have any input into before the pandemic. Suddenly we felt a duty to get PPE to care homes, and we provided it for free. So I got a lot of positive feedback about that element of what we did, and the other huge amounts of support that we put into care homes.
Free PPE, I think, was provided on the 20th of July, or that's certainly when you authorised that. Are you able to help with...
I'm not sure that's right.
All right, well, we'll come to the detail when we look at PPE in due course. But
sure.
What I wanted to ask is, prior to the rollout of free PPE, did you perform any visits to care homes in March, April, May 2020? Can you recall?
Not physically. That would have been totally inappropriate.
No, I prefaced the first question with either in person or virtually.
Yeah, I can't remember. I may well have done,
okay.
But I was also dealing with a national pandemic. You have to remember the context. I'm also dealing with driving testing, lockdowns. I had COVID myself. Obviously, the vaccine programme. I was pretty busy.
Mr. Hancock, Ms. Carey asked you about what you learnt from your visits, either in person or remotely with care homes, and you mentioned two positive things: provision of free PPE and the support, you say, that was going into care homes. Did you learn anything negative about what was going on in care homes?
Well, care homes were having a terrible time. I mean,
So what did you learn?
I learned that those on the ground in care homes were working unbelievably hard to try to support those who were in their care, and they were having a torrid time with it. I take that as read. Sorry, I absolutely should acknowledge that quite rightly. I also, one of the other things that that I talked to the care homes I spoke to or visited about was this incredibly difficult challenge of visitor policy. So we knew that when there was spread of COVID in the community, visitors were likely to increase the risk to care home residents, which could be a fatal risk. But at the same time, lack of visiting is incredibly painful and can be damaging, especially for instance, to those with dementia. And you couldn't fail to be moved by the impact of the visitor restrictions. And there was one point during this period when I was being legally challenged, both in favour of more visiting and against visiting at the same time. In a way, visitor policy captures the fact that there were just no good choices in many areas, and it fell to us to try to strike the best balance. So visitor policy was often something I discussed. As it happens, most care homes, in my recollection, strongly supported the restriction on visitors because they wanted to keep their residents safe. But at the same time, they acknowledged the emotional and potential medical impact of that restriction.
We've jumped ahead, but can I come back?
No, but I'm grateful for the opportunity to set that out more broadly than I did in my first answer.
No, not at all, and we will come back to visitor restrictions. All right. Can I ask you, please, though, to go back to February 2020, please, and the initial response to the pandemic? And you set out in your statement, at paragraph 52, for those who are following, that pandemic contingency plans were prepared by local authorities.
Yeah.
A note of a meeting with officials on the 11th of February 2020 records I'd indicated the primary responsibility for planning the adult social care sector's response to the pandemic was for local authorities.
Yeah.
And I think you are aware that you raised that with Helen Whately.
Yeah.
She had made some inquiries to obtain two pandemic contingency plans.
Yeah.
And it was her opinion that those plans, if I may put it colloquially, were not up to scratch.
Absolutely right. It was a really shocking moment, yeah.
Did you yourself look at the two plans that Miss Whately had obtained?
I did. It did not take long to work out that they were wholly inadequate.
All right. And are you able to tell us in what way, in general terms, you considered them to be inadequate?
A broad brush, high level, not practical, without practical recommendations. But there's something much, much deeper, which comes back to the point I made in my very first appearance as a witness at this inquiry, which is about the doctrine that underpinned the medical advice and therefore the government approach to pandemics, which is embedded in the 2011 strategy, which is that if your plan is not to try to stop a pandemic, but is to deal with the consequences of a novel pathogen ripping through the community, then there are different elements. You have a different approach. And so the plans were based on essentially trying to cope with a virus that had a bad impact on older people, rather than trying to stop it from ripping through in the first place. The same doctrine problem in what underpinned this whole area, and it took a huge amount of effort to change that over the course from when the penny really dropped with me in the middle of February, over the period of the next couple of months.
from your perspective, ahead of the pandemic, who had responsibility for checking the adequacy or otherwise of the pre-pandemic plans?
Local authorities.
Right. When you found out from Miss Whately that there were at least 2 out there that were inadequate...
It was worse than that. She could only find 2 and they were inadequate.
Yeah. When she found that only 2 and they were inadequate, what did you do to try and ensure that there were decent and adequate plans in place?
So at that point, we realised that far from relying on the existing governance structure, we were going to have to put out guidance from the centre and essentially make an assumption that care facilities didn't have a pandemic plan. That's what we realised. And so the first guidance to care homes went out in February. And that was essentially, we decided that we needed to have a national approach to making recommendations to care homes, rather than being able to rely on care homes and local authorities having plans, adequate plans for themselves. So I was dealing with these 2 problems, which is the national plans were based on the wrong doctrine, and I realised that between the end of January and the middle of February, and the local plans were as good as useless, and therefore we put in place national guidance, which, as you know, changed over time as the clinical advice changed.
Right. That first piece of guidance, I think, was issued on the 25th of February. And can I have up on screen, please, INQ 499433 _ page 7. This was the guidance for social, community care and residential settings on COVID-19. You will see there the guidance at that time on face masks was that face masks do not provide protection from respiratory viruses such as COVID-19 and do not need to be worn by staff in any of these settings.
Yeah.
Only if recommended essentially or advised by a healthcare worker. It remains very unlikely that people receiving care in a care home or the community will become infected.
Yeah.
Now, this is PHE guidance.
Yeah.
I appreciate that. But does that reflect your understanding as at 25th of February that it was very unlikely that people receiving care in a care home or the community will become infected?
No, this is, I mean, there's 2 problems here, obvious. One is that the clinical advice on face masks was confused for a long period of time during the pandemic. And that confusion it can be seen here. It is true that at this point, the number of infections in the UK was extremely low.
Correct.
And so it remains unlikely that people receiving care in a care home or the community will be infected would have been true. But that word is not be, it's become. And by this time, we knew that there was a very serious problem. So I have no idea why PHE stated that. We have a...
Sorry, just to interrupt. Can I just correct the answer? You said the number of infections in the UK was extremely low. The number of infections that we knew about, was it?
Correct.
Yeah.
Compared to what came, both are true. The number of infections we knew about and had was very low, yes.
So, in short, this doesn't necessarily reflect your understanding.
I was in a battle with PHE at this point, right?
Yes or no? Does this reflect your understanding as at the 25th of February?
No, I wouldn't say become. I'd say be. Will be infected.
All right.
Yeah. This comes back to asymptomatic transmission. Unless you want, obviously we've covered asymptomatic transmission in many modules, but since the last module, it has come to my attention that on the 27th of January, I insisted in a meeting that I was concerned by reports from the Chinese government about asymptomatic transmission. Hold on, and set out the need to plan for the reasonable worst based scenario in that respect. That's INQ 00106067. So from January, I was requesting the system to base its planning assumptions on asymptomatic transmission, and I didn't get PHE to take that on board until April. And this guidance from PHE is a representation of that problem.
So from your perspective, had this been passed over your eyes for agreement or otherwise, and I'm not saying it should have been, but had it have been, you would not have allowed the guidance to go out with that line in it, based on your understanding of asymptomatic transmission at that time?
If I had read this in draft, I would have said, I would have changed it to the present tense rather than the future tense. It was already clear that we were going to have a major pandemic, and that was to me that was obvious. But what's even more frustrating is it was obvious to the team around me as well. I mean, this is late February. We were, we'd switched into full pandemic planning mode from the end of January in the department.
That can come down, thank you. That was as at the 25th of February 2020. The two plans that we've just spoke about that were inadequate were sent to you on the 3rd of March. Miss Whately told you in some WhatsApps that they were inadequate. She said to you that essentially the plans didn't really say very much, as you've just acknowledged. And in a WhatsApp back to her, you said this: can you possibly put some serious drive into getting them to a credible position? CMO tells me there's guidance to social care being developed to publish. Seems to me we need to do a lot of work here. And she says, absolutely right, it's taken a week even to get these two example plans in a meeting. You are right, it needs a rocket under it.
A rocket, absolutely.
Right. And I take it from that answer that you've just given that you agreed with the Minister it did need a rocket.
No, I 100% I agreed with the Minister. You know, during this period, from late January through to early March, we in the department were pushing every button we could to get action. You know, you'll recall from other modules that I was calling for COBRA meetings. I was being blocked from having COBRA meetings. I was trying to drive action on testing. I was being blocked by PHE from expanding testing using the private sector. I was being told that it would take 5 years to get a vaccine and insisting that we had one by Christmas. There was a small team of us who were driving incredibly hard and getting blocked. For instance, I was trying to publish the recommendations on likely actions we might have to take in terms of lockdown and getting blocked by number 10 from doing that, which eventually went out in early March. And this is just another example of it. I cannot for the life of me understand why PHE would make a statement like that when it was so clear that we were running into a major problem. And it is a deep frustration that even as Secretary of State, I couldn't get them to change their clinical guidance.
Can I just ask, I'm sorry if I don't really follow how, PHE was an independent agency, but responsible to the Department of Health and Social Care?
Through the CMO, yes. And I spoke to the Chief Executive.
So why doesn't the Secretary of State for Health and Social Care have any levers over PHE?
You may very well ask, because of the behaviour of some of the senior officials. So, for instance, when I said in January, I want the serum that we have to be made available to the private sector so they can expand testing, they didn't do it, right? It's astonishing that we haven't got PHE senior officials at this inquiry, and they've essentially not been asked these questions. It was a enormous... I'm
afraid we have had officials from Public Health England and UXA, Mr Hancock. So.
No, these questions have not really been aired. I got so frustrated with PHE, I abolished them, right? Because they were so poor in their responsiveness. I took responsibility for testing away from them. It is wholly unfathomable to me that they didn't change the advice on asymptomatic transmission, even to acknowledge that asymptomatic transmission might happen until April. And as you can see from my exchanges with Helen Whately, as ministers, we were extremely worried about this. But when you have independent agencies that do not accept the writ of a minister, it's a challenge. They were backed up by the World Health Organization, remember? So it's like, do you do what the Secretary of State with his lay understanding and my intuitions says, or do you do what the World Health Organization is telling us, which is there's no asymptomatic transmission, everybody please calm down. They delayed calling a public health emergency of international concern. So it was a period of intense frustration for my ministers and I, as you can see from the text exchanges.
But if you felt so strongly, what could you as Secretary of State not do if you felt that an agency for which you were ultimately responsible?
Yes. So eventually...
Couldn't you insist
yes.
and call people in?
Yes, I called people in, yes. I had them into my office. Eventually I stripped them of their responsibilities. But it took me until mid-March to do that on testing. On clinical advice, it's very hard to strip your clinical advisors of because I couldn't write clinical advice because I'm not a doctor. So what I could do is challenge clinical advice and challenge some of the executive decisions. But when this is one of the challenges of the interaction of clinical advice and policy, is that in order successfully to challenge clinical advice, I essentially had to persuade other clinicians like Chris Whitty to overrule, which they would only do on the basis of scientific evidence, and this was an enormous challenge. But you can see at the time how frustrated we were as ministers at the lack of responsiveness in the system to this problem.
Can I move 3 days on from the rocket WhatsApp, please, to the 6th of March and a coronavirus and social care meeting on that date? And could I have up on screen, please, INQ 4049530. There's a number of matters I'd like to ask you about this document, please, Mr. Hancock. We can see that you opened the meeting by stating the impact of the virus, which poses a complicated set of problems on the social care sector due to the higher risk for older people and the need to be gripped as soon as possible. What did you mean when you used the phrase, it needed to be gripped?
Well, at this point, it had come to my attention that, as we've just discussed, that the plans that were in place in the formal line of accountability for social care were wholly inadequate. And what I mean, I think, by this is that at a national level, we need to take the action that should already have been in place at a local level. And essentially, we needed to take responsibility for the response. So there's, and you see this in a whole series of areas. The department took responsibility and for a series of areas over this period because we realised that the preparations had been flawed because of the wrong doctrine and that there was not enough being done in other areas. We were not formally responsible for the delivery of infection control, for instance, in the care sector, because that was technically a local authority responsibility. But we needed to just do it. And throughout all these modules, you've seen this in a series. This is what it felt like, right? We've seen this in a series of different areas, and I apologise that this is not an answer within solely this module, but it is important for this module. There's a whole series of areas, this, testing, vaccines, where we in the department, under my leadership with the CMO, decided to take the action that ought to have been happening or ought to have happened and grip it.
Right.
That's
what I want. Yeah, but what did you actually do to grip it?
Well, shortly after this, we put out further advice.
Yep.
We increased the amount of money, and over the next 2 months, we put £5.1 billion in the hands of care homes. We provided free PPE. Obviously, when tests became available, we made them very high in the priority order after hospitals and made them available for tests for staff and residents. We took, for instance, responsibility for visiting policy, which normally would have been a local question. We took that took those decisions at a national level.
Right.
And then we got on to, once it became clear that staff movement was the primary issue, we got on to, firstly, advising against staff movement and then trying to get a legal ban on staff movement.
No, I understand that, and there's a number of things you subsequently did, but
That's
as at the 6th of March,
Yeah.
what I was trying to understand is what did you actually do there and then to grip the problem?
We gripped all of those issues in time. The central point about this, what I mean by need to be gripped, is we need to take responsibility. I don't care that it's not our legal responsibility. Right. And actually, I don't care if people get upset about it. You know, we've seen even from this very chair, people who were upset about me taking action that was necessary. I ruffled some feathers. They were rude about me at the time. They've been rude about me since, but it saved lives, and that was my duty as Secretary of State.
Can we come back to the document?
That's what it says.
Can we come back to the document, please, and look at the fourth bullet point down. The Secretary of State flagged the most contentious item in the bill, which I assume is the coronavirus bill, is to raise the threshold for giving
of PPE. Then it's reasonable that you might understand the order in which life-saving support is needed. But I don't know specifically what it is, what this is, which particular area of policy this is referring to.
Well, so I understand it. I want to be clear. You can't remember now at this remove what the this is referring to. Is that correct? It might
no,
be PPE.
I can't. It
right?
may be. I don't know.
But just thinking about the actual hierarchy itself, can you help now with why residential homes came before nursing homes?
No, I think any hierarchy like that, I would take clinical advice on. So, for instance, the hierarchy of who got vaccines first, care homes were right at the top of that. Who got PPE first, who got testing first. In the case of those two, hospitals were at the top of the clinical hierarchy. But any question like that would be based on the evidence, and I'd base it on clinical advice.
All right. On any view, given the number of people in receipt and indeed providing domiciliary care, can you help now with why domiciliary care is at the bottom of the hierarchy?
Well, it depends what we were talking about, so it's impossible to say with precision. But for instance, if it is about the provision of PPE, then that may well have been my clinical advice that the order in which PPE it protects most may well be that order, but I can't. But we don't know what this is referring to. It's certainly not that I thought of these three elements of care services in a rank order in that way. It depends specifically what the note is referring to.
A little lower down the page, there was a discussion on workforce. DCMO Jenny Harries flagging workforce shortages and noting the majority of nursing home staff are not clinical.
Yeah.
And she flagged the risk of double counting capacity. So she's putting out there on the 6th of March the problems with the workforce. And then can I ask, please, that we go over the page to the bullet point, second bullet point, Secretary of State summarised there is work to be done and issues to solve on
10 work areas.
10 different areas, workforce being one of them, financial support, excess deaths, data, support for non-COVID illnesses, equipment, local resilience forum readiness, collaboration, comms and the bill. Noting the big question is if we've got enough of a team or a system in place to be able to do everything we can. Were you concerned that as at the 6th of March there wasn't enough people dealing with the adult social care response within the Department of Health and Social Care?
Yes, of course. We were unbelievably stretched in all areas. And I'm summarising here work needed in 10 different areas, in many of which we would not have had as a department a locus on in normal times. Financial support is not something that the Department for Health and Social Care would lead on in normal times. And so, yes, of course, there was enormous pressure. What you can see is me driving the system because we were essentially taking responsibility from around 50 local authorities that were nominally and formally and legally responsible for this area, and we were taking it on our shoulders to try to fix these problems.
Can you help me with why one of the areas that is not mentioned, why isn't IPC mentioned in there, Mr Hancock?
I don't know.
Was IPC on the radar at that stage as being
Yes,
a way
it
of
is. PPE is
well,
mentioned.
PPE is a form.
PPE is one element of it.
Yeah.
Yeah. I don't know. No. It may well have been, and it depends whether it was not. It was definitely on the radar, absolute 100%.
So there we were as at the 6th of March 2020. And can I ask you, please, about a follow-up meeting on the 11th of March? And can we go to INQ 000328-131? This was a social care and coronavirus meeting. Thank you very much. Ros Broughton is flagging the importance of engagement with the sector. There are 3 pieces of guidance that in fact came out on the 13th of March, and clearly they were being discussed. And the bullet point starting just below that, Secretary of State asked about providers paying staff if they are ill, and asked to self-isolate in order to disincentivise staff with milder conditions going to work with older people. I'd just like to have your explanation, please, of what it was you were worried about and why you were asking about disincentivising staff with milder conditions from going to work.
So in a way, this is an early indication of what became the staff movement restriction issue. It was clear to me that if staff are ill, then they shouldn't be going to work. However, in this country, sickness pay is absurdly low, and many people find it difficult not to go to work because of the ridiculously low levels of sick pay. And that leads to disease spreading in the workplace. If you work in a care home, of course, that leads to disease spreading to some of the most vulnerable people in the country. And this happens every winter with flu. And people die unnecessarily because of it. And that's what I'm worried about. People who are ill being asked to self-isolate and not being incentivized to do so. Many people are paid hourly, and if you don't do the hours because you're ill, you don't get paid. And obviously, we later had this debate in a much bigger sense with people who members of the public asked to self-isolate. But it's even more important if the self-isolation is isolating yourself from giving some of the most vulnerable people the disease.
And just on final bullet point there, Ros Broughton flagged a number of providers will not be in contact with local authorities. The Minister suggested using the CQC as a mechanism, and you were in agreement with that approach. There was discussion on people who are on 0-hour contracts and being paid through statutory sick pay. Secretary noted working with HMT to solve this.
Yeah, that didn't get anywhere.
Well, that's what I was going to ask. It didn't get anywhere.
No, sick pay is... I think we did increase sick pay a bit for the period of the pandemic. It's not something I've looked into and in preparation for this module, but it'll be publicly available. I think we increased it somewhat, but it's still... It's now gone back to ridiculously low levels. We're far below any European comparator on sick pay. But there you go. That's the discussion that we were having.
All right. So that is as we are at the 11th of March 2020.
If I just also, it is worth noting that Ros here is flagging the number of providers not in contact with local authorities, and because the CQC was one mechanism, but this question of where is the total register of a full and canonical register of care providers was something that we were struggling with at this stage.
Can I turn, please, to ask you about the hospital discharge policy, Mr. Hancock? And at the outset, can we be clear? Was it one person's decision?
No.
Right. Who or which department's decision was it?
Well, it was formally a government decision. It was signed off by the Prime Minister. It was really driven by Simon Stevens, the chief executive of the NHS, but it was widely discussed, both in the department, with the NHS, and with the centre.
Yeah, you said in your statement, in fact, that NHS England insisted on the policy.
Yes.
And you later in your statement said, although I did not take the decision, I take responsibility for it.
Yes, for two reasons. The first is it was a decision of the government, and I was the Secretary of State. And I take responsibility for all of the decisions in the area that I was responsible for. The second is that whilst this is obviously an incredibly contentious issue, as I also said in my statement, nobody has yet provided me with an alternative that was available at the time that would have saved more lives. There are things that we can do now, and indeed should have been doing for the last 3 years since this inquiry was set up, to make sure we're better prepared, and we went through some of those right at the start. But obviously, having racked my brains about this and thought about it incredibly hard, and in preparation for this inquiry, having gone through all of the paperwork, I still can't see a decision that would have been less bad. None of the options were good.
No. Do I take it that it was, from your perspective, the least bad decision, the least worst decision?
That's exactly my view, is
Right.
that it's the least worst decision that could have been taken
Right.
at the time.
But it was a decision nonetheless that you agreed with at the time?
I accepted it. I wasn't the driving force, but it was the decision of the government, yes.
The question I asked you, was it a decision you agreed with at the time?
Yes. I defended it at the time. And whilst I wish that there had been a better option, I still can't find one.
Now, in the run-up to the decision and the letter going out from NHS England on the 17th of March, there were a number of meetings about this, and I'm not going to take you through all of them. It includes COBRA, various pandemic meetings, departmental meetings.
And then there were informal discussions as well.
Quite, absolutely. But in amongst the myriad of meetings, can you help with who was there really to represent the views of the sector when these decisions were being made?
The loudest voices in representation of the sector were Ros Rawton,
Right.
Helen Whately, and me.
And what were you saying in your loud voice, Mr. Hancock?
Well, of those three, the other two were the louder, because my job was to balance requirements across different parts of the health and social care sector. Their position was to stick up for social care. And as you see in the paperwork, there are Helen Whately in particular was fighting a battle to find alternative ways of ensuring that you could carry out this a policy that was that would protect more lives. That was the battle. The challenge was that hospitals were likely to be overwhelmed, and that hospitals were very dangerous places because of the spread of the disease. And so the likelihood of things being worse had more people stayed in hospital is very high. So that wasn't a good option. And the many care homes didn't have isolation facilities, so that wasn't an available option. And we didn't have enough tests. Remember, at the same time, I'm driving the number of tests, and within a couple of weeks, we got to the position that there were enough tests, but there weren't at this stage, because the clinical advice, which I think was right, was that tests are more necessary for those who are in hospital with COVID. So it was as opposed to people who aren't symptomatic, and we can come to the clinical advice saying that tests were inappropriate for those who were asymptomatic. So that was the nexus of problems that we were dealing with.
Now, your statement sets out the predicted need for, I think, 390,000 people needing ventilators. That was the position at the 2nd of March. By the 9th of March, there's suggested to be a deficit of 780,000 beds. eye-watering numbers on any view.
Yeah.
And I just say that to provide a little context for
Yeah.
a document I'd like to look at, please. Can we have on screen INQ 000325 This is a DHSC note which outlined a number of options when considering freeing up hospital beds by discharging patients. It's dated, Mr. Hancock, the 12th of March, but according to DHSC, it was presented to you on the 17th of March. All right. And the question is, how can we free up hospital bed capacity by rapidly discharging people into social care? They set out the number of people that there are delayed transfers of care, which was a pre-pandemic issue in any event.
Yeah.
And then they are, if we just scroll down the page, there is an acknowledgement that there are workforce constraints, would be a limiting factor to the ability to discharge people. There's currently 120,000 vacancies, and our reasonable worst case model would have another 11% of staff off in the peak week of the pandemic.
Yeah.
Which would be another 176,000. Furthermore, you've got vacancy rates which are significantly higher in the South East and London. So in essence, you may be discharging people to care homes where there isn't the staff, either pre-pandemic or exacerbated by ill health caused by the pandemic, to be able to care for those people. Is that essentially what it's saying?
No, it's not.
Well, help us, please. How do you interpret
it's
this?
saying that there is a challenge and a rate limiting factor. The way you put it, I think, is more extreme than the way that it's considered. But it was a significant pressure, I think, is the best way of putting it. Further context, for instance, is that earlier in the pandemic in January, or I think in February, we'd seen examples internationally, for instance, of people dying in care homes, not from COVID, but because all of the staff had abandoned the care home. That example came from Spain. We saw examples of outbreaks in care homes. We knew that there was a very significant problem, but there was a problem on both sides, that we needed to have the staff and we needed to be able to look after people.
Right. Given the constraints, though, was it not of a concern to you that there may be discharges from hospital that are expedited where there weren't the staff to be able to care for them properly?
We knew that there'd be pressures, but we also knew that people were rising to these pressures. In normal times, that would be a bigger worry. We knew that people would do what they needed to do. There were many instances. Remember, at the same time, we're thinking about pressures in hospitals where nursing ratios in intensive care went from 1 to 1 to 1 to 6.
Yeah.
So the absolute way in which you put the question is not how we were thinking about it. How we were thinking about it was in terms of the incredible pressure on adult social care staff.
Right. So there is an acknowledgement by you that expedited discharges would increase the pressure on an already constrained workforce.
Yes, that's a very reasonable way of putting it.
And a number of options are set out there. There was extending free care to speed up the discharge. There was removing the continuing healthcare assessment. There was rolling out capacity trackers, greater use of the independent sector, and the use of live-in carers. So they were all options that were being considered around the time of the discharge decision.
Yeah.
And I think in due course, can I invite us please to look at page 2 of the document. There's under the section dealing with joint arrangements. Mr. Hancock, can you see the underlined section? To note, we need a clinical decision on whether this is the right thing to do. The policy implies that emptying the hospital is more important than protecting residential or domiciliary care capacity to support people currently in the community. We would need this to be taken on a clinical basis.
Yes.
And did you see that comment on whether this was the right thing to do?
Of course, this was something that was, as you said earlier, it was a question of what is the least worst solution to this terrible problem. And the clinical advice was obviously a critical part of the policy making.
do you agree that the policy implies to some that it does look like that the emptying of hospital and freeing up NHS capacity is more important than the impact that it had on the care sector?
What I care about here is the substance. The substance at the time is that I can't find a less bad solution than the one we went ahead with. Then the consideration for the future is about the preparation that's needed now to avoid exactly this sort of impossible choice.
All right. And so we come to the 17th of March when the NHS England letter goes out to health boards, trusts, etc., saying, please start the discharge. As at the 17th of March 2020, do you agree that there was not enough testing capacity to test all patients being discharged?
Absolutely, yes.
You've told us that you were worried about asymptomatic transmission.
Yes.
But there was no scientific agreement about the extent to which it was a problem.
That's correct.
As at the 17th of March, do you agree that there was not enough PPE in care homes at that stage?
It depends what you mean by not enough. We definitely would have wanted more, and we were pushing very hard to get more, and that was a major issue. Yes.
Do you agree that at the 17th of March, IPC training had not yet been rolled out to the care homes to help them with donning and doffing and the like?
That was needed. It was
May.
absolutely needed. Yeah, as part of this package.
And the guidance that accompanied the discharge did not advise the care home to isolate any patient being discharged from hospital, did it?
That is absolutely true, and that comes back to this clinical advice that on asymptomatic transmission that we've covered in other modules, and the emphatic advice from PHE, backed by the World Health Organization, until April. That we should plan on the basis of no asymptomatic transmission. That was a mistake. It was a mistake I challenged at the time, but as a non-clinician, it was not a mistake I could overrule.
All right. And as at this time, staff movement as between care homes is not banned or even advised against?
No, at this point, because of the lack of understanding around asymptomatic transmission, consideration had not yet been given to banning staff movement, and we came to that later.
Right. So taking all of those factors into account, can you help then, against that background, how people in care homes were to be protective as at the 17th of March?
Well, at that point, the best thing that could have happened to somebody leaving hospital would be to treat them as if they had COVID and to isolate them as such. Those sorts of facilities were not universally available, though.
Do you think it was an error now to not have directed that all untested patients should have been isolated when they were transferred to a care home?
With hindsight, that is absolutely right. At the time, with the clinical advice on asymptomatic transmission, that is not what was clinically recommended, but absolutely.
We know that in due course you gave a daily press conference on the 15th of May, which included you saying right from the start we've tried to throw a protective ring around our care homes. We set out our first advice in February, and as the virus grew we strengthened it throughout. And you went on to set out the measures that you say the government had taken, and you said again from the start, we've worked incredibly hard to throw that protective ring around our care homes. Yes, it's been difficult. These viruses reserve their full cruelty for those who are the physically weakest, the elderly, the frail, and the already sick. Now, I appreciate, Mr. Hancock, that you've subsequently acknowledged that, notwithstanding all the measures, there was no unbroken circle, to use the phrase that was put to you in Module 2.
Yeah.
But can I ask you, why, as at the 15th March, was it suggested that there was a protective ring, given all of the absence of things that we've just looked at?
Well, we've also been looking at all of the things that we did do. So by the 15th of March, we'd brought in 88 separate measures, including over £5 billion of funding. And testing by that stage available to all staff and residents. We've discussed the free PPE. We had brought in advice and support. We'd given a clinical lead for each care home. There were a whole series of measures that we had brought in. I would stress, this, in that piece of rhetoric, what I said is that we had tried. It was not possible to protect as much as I would have wanted. And that is the central task of the inquiry, to work out what we can do right now, frankly, what should have already been happening in care homes, because there has not been enough action to prepare for the unknown date, which could be tomorrow, when we will get the next deadly pathogen. And in fact, the national debate on this has gone backwards, with prominent people saying that even the actions that we did take were a mistake. So it is urgent now that this action's taken for the future, but I hope that's my explanation of why I use those particular words based on the substance at the time.
Could we just rewind for a second? Ms Carey very carefully asked you the question, focusing as at March, what was the protective ring? And you mentioned, for example, PPE. I thought Ms Carey told me earlier that that wasn't available until the 20th of July. So
No, that's not right. In March, we made the first actions to start to get free PPE out to care homes.
Yeah, in March, I think there was a drop which resulted in about 300 face masks going to each care home, Mr. Hancock. So, on any view, that's not going to last particularly long, is it?
I don't think it's appropriate to belittle the efforts that started in March. There was a huge amount of work to get free PPE out to care homes. And it started in March and it grew over time. But I don't think laughing at that is.
I'm not belittling it. Well, but we'll
if anybody laughs at any evidence, Mr. Hancock, I'll be the one to correct them. Thank you very much.
All right. Her ladyship's question, though, was if you look at the position as at the 17th of March, what was the protection that was provided to care homes as at the date that the letter went out saying discharge anyone who's medically fit?
Well, at that point, we were starting the work of getting the PPE out. Right. Remember that PPE was the responsibility of care homes themselves before the pandemic.
Yeah.
We come back to the 6th of March meeting when I said we needed to grip this, i.e. the department needed to take responsibility. It was from then that we got going on ensuring a supply of PPE, which started, we started with as much as we could get our hands on, and grew over time.
All right. So it may be me. I'm just trying to understand. If we don't have testing, there is an inadequacy of PPE. You can't isolate, and the advice doesn't say isolate. You're not banning staff. What was the protection for the care homes, Mr. Hancock?
The question we faced was, what is the best policy?
That's not what I asked you.
It may not be what you asked, but it is the question that was valid at the time. You see, if you take these questions out of context, then you are not asking the real question that we faced. The protection, at the time, was clearly not as much as we would have liked, but the alternatives were even worse.
Now, you say it was not as much as we would have liked, but what was it? That's what I'm trying to understand.
Well, we started the flow of free PPE. We were testing those with symptoms.
Yep.
We were not testing asymptomatically because of the clinical advice and the shortage of tests. The expansion of testing, which we were in the middle of, which we expanded rapidly in the days following that announcement, and in particular over the month of April, these were all the protections that we were putting in place. We were trying to put as much protection in place as possible. And all I can do is take you back to the actual decisions and the resources that we had at that moment. We did not have enough. We did not have enough, right? The preparation had been inadequate. The department I had taken the decision to take responsibility for a series of things that had not been done. I am held accountable for those actions. But the actions, I've reviewed every piece of paper in preparation for this module. And what I can tell you is from the moment we gripped this, we started one by one solving these problems. You do not have to tell me how great the challenges were, how little protection there was for the public. There wasn't enough PPE there wasn't enough testing, right? There wasn't enough PPE. We didn't have the right, the public health authorities had the wrong attitude and the wrong doctrine, okay? All of these things needed fixing, and one by one, we did everything we could to fix them. The challenge we have now is to say what is ready for next time, okay? And that's the answer. It's the only answer I can give is the answer based on the truth of what the situation was at the time. Remember at the time, I also had Dominic Cummings, a load of people causing all sorts of problems for me, and I had COVID.
All right. Let me ask you this, and then perhaps my lady will take our mid-morning break, if we may. At the time you stood on that press conference, did you believe it to be true when you said we had tried to put a protective ring around the care homes?
Yes, and I will stress the word tried. We were trying to do everything that we possibly could. We were in bleak circumstances, and from any international comparison, everybody had the same problem, which was that the care of those people who were most vulnerable were also those caring for those who were most vulnerable to COVID.
I ask you that because I think you are aware of some evidence that has been obtained by the inquiry where people considered you to have lied in that press conference, Mr. Hancock. One person in particular said he blatantly lied about the situation with care homes. There was no blanket of protection. We were left to sail our own ships. He wasn't heartfelt. He had no understanding or appreciation of the challenges care homes face, pandemic or not. It felt like we were the sacrifice, a cull of older people who could no longer contribute to the society.
Yes, I've seen that evidence. I understand that we're not stating who it's from, so it's anonymous. But they also go on in that evidence to say we're grateful for the money and various other elements of support that came to care homes. Well, that came from the same people. So, you know, I could quote people who got in contact to say thank you. I don't think it is instructive or helpful of the inquiry to exchange brickbats like this. The importance of this inquiry, and by God, we've had long enough, right? It's 3 years since this inquiry started, and we still haven't made the changes to this country that are needed. We've waited 3 years to come to probably the most important and sensitive element of it because of the modular system. And here we are, still, I think, in a worse situation than before. And so, sure, I ruffled feathers in getting stuff done, but and people have had a go at me over it. But I've been through everything that we did as a department, a big team effort, and we were all pulling as hard as we possibly could to save lives. That's what I meant by saying that we tried to throw a protective ring around. Of course, it wasn't perfect. It was impossible. It was an unprecedented pandemic, and the context was exceptionally difficult.
Right. You've told us in both your statement and indeed in your evidence a moment ago that this was rhetoric by you. Can we be clear? What do you mean by the word rhetoric?
I mean, it was a form of words rather than the substance. I've repeated the substance of what we were doing to support the care sector.
I ask, Mr. Hancock, because some take rhetoric to mean it sounds impressive, but it lacks substance. And so I want to be clear what you meant by the word rhetoric.
I meant it's a form of words, but what you should look at is the policy support that was put in place from the centre. And that's what we did. All I can tell you is that the other options available, given the clinical advice I had at the time, were worse.
Right. On the day that you gave that press conference, I think you had access to SITREP data, which showed the number of deaths in care homes at that stage, which, depending on which database you use, were somewhere around 8,000 odd people in care homes who had died. And at that stage, on the 15th of May, 37% of care homes reported an outbreak, and in the northeast, there was 48.9% of care homes reporting an outbreak.
Yeah.
Were you aware of this data at the time you said in the press conference that there was the protective ring?
Of course I was aware of it. Of course I was aware of it. I was the it's very strange, this questioning. I was the Secretary of State. I had taken personal responsibility for this area, despite not having the formal accountability for it. At the same time, on the same day, we had the announcement of a further funding allocation.
Yeah.
So, yes, of course I was aware of it. And the action that I and the team were taking, and Helen Whately and Roz and everybody else in the department, was to try to save as many lives as possible. And perfectly reasonable for you to question the exact words that I used, but what I care about is the substance of what we did, the protections that we put in place, and most importantly, what we can do in the future to ensure that the options available are better than they were last time.
All right. Finally, this please, on this topic. Do you think a member of the public, or indeed people running care homes, would interpret what you said as a piece of rhetoric?
Yes, I think largely people in running care homes would understand that what I was trying to say was that we have tried to put in a huge amount of support. That's the lived experience I have from talking to people in care homes. You know, there may be campaign groups and politically motivated bodies that say other things. What I care about, though, is the substance. And frankly, that's what this inquiry should care about after all the millions of pounds that have been spent on it.
And I can assure you, Mr Hancock, it is what I care about. On that note, we'll come back at 11:45.
Thank you, my lady.
All rise.
Thanks, Karen.
Thank you, my lady. Mr Hancock, I'd like to finish with a few questions more about the hospital discharge policy, and then I'd like to move on to staff movement and attempts to restrict staff movement.
Yeah.
All right. So can we just look at perhaps some of the guidance that touched on the discharge policy? Clearly, there was the policy that came out on the 17th of March. There was guidance on the 19th of March. There was updated an admissions guidance on the 2nd of April. And can I have up on screen, please, INQ 325-255_0005. This was the admissions guidance as at the 2nd of April. Again, as with the PHE guidance that we looked at from the 25th of February, you can see when it's dealing with admissions of residents, reference there to the care sector looks after many of the most vulnerable people in our society. As part of the national effort, the care sector also plays a vital role in accepting patients as they are discharged from hospital, both because recuperation is better in non-acute settings and because hospitals need to have enough beds to treat acutely sick patients. Residents may also be admitted to a care home from a home setting. Some of these patients may have COVID, whether symptomatic or asymptomatic. All of these patients can be safely cared for in a care home if this guidance is followed. Now, do you remember seeing this piece of guidance, Mr Hancock?
I was not closely involved in writing it, but it was signed off by the department.
Right. Did you think, as at the 2nd of April, all patients discharged, whether symptomatic or asymptomatic, could be safely cared for in a care home if the guidance was followed?
Well, that was based on the best clinical advice. I can't recall exactly how I felt about it at that time, whilst this was developed, this guidance, whilst I myself was at home with COVID.
All right. It was before, so that you recall, the change in testing pre-discharge, which came on the 15th of April.
That's right, and it was published, I think, on the 2nd. I think it was published the day before the CDC changed the international advice on asymptomatic testing, and the changes, and that finally got PHE to change on that position.
What I wanted to ask you about was some questions about some developments between the 2nd of April guidance that we've got on screen and the 15th of April action plan, when there was the change to the testing pre-discharge. All right, so can we just think about that period of time, please? And it may help you, Mr Hancock, if we have up on screen some WhatsApps you had with Helen Whately. Can I have INQ 475068 on screen? And there are a number of different topics that are in this WhatsApp, but I just want to try and look at the ones that impinge on the discharge policy. And at 10:16, can we see there a message from Helen Whately? The discharge policy is my biggest concern. She says that's an argument with Simon, presumably Simon Stevens, clearly. Dom Cummings asks for more detail on testing and PPE.
Not necessarily, that may be Dom Raab.
Right, thank you. Either one or of them.
I think it will have been Dom Raab, because I think Don Cummings was away at this point.
All right. So possibly Mr Raab his asks are for more detail on testing and PPE. They are the same as hers have been for the last few days. No one seems able to give it. And then the thread picks up again, in fact, later that evening, at 21:56. So could we go to page 2, please?
Right.
And it's not that I'm deliberately skipping over some, but different topics crop up in the WhatsApp. But to return to the discharge policy, there we are now at 9:45 in the evening. You saying to Helen Whately, have you agreed a discharge policy with NHSE? And Helen says NHS won't keep them in an NHS setting if fit for discharge. We can't force care homes to take them if COVID infection risk. However, some may have isolation COVID positive zones, so can. And if not, we advise local authorities secure appropriate alternative care arrangements. For example, a local authority commissioned isolation facility. And a little bit you say that sounds messy. Now, are you able just to give us an overview of what is the argument or disagreement or concern as at the 13th of April in the run-up to the publication of the action plan?
Well, at this point, of course, the clinical assumption on asymptomatic transmission had changed. And therefore, I am concerned that advising local authorities to secure appropriate alternative care arrangements is going to be complicated. My recollection is that Helen was pushing for the NHS setting aside certain NHS settings, because by now the numbers in hospital, we'd got some further, we'd got the Nightingales up and running, so there was more capacity. I think Helen was driving for the NHS to keep people in an NHS setting, and the NHS were not accepting that. And so clearly a policy compromise had been made, which is advising local authorities to secure appropriate alternative care.
So can I see if I've understood this correctly? The argument really is before discharge, should they be quarantined in the NHS in a hospital estate, or should they be quarantined post-discharge in a care home? Is that the two competing sides?
Well, really the question is where to quarantine
yes,
people.
Where? In hospital?
But nobody thought that it was a good idea to keep them in a standard general hospital setting, right?
I follow you.
But would there be other NHS settings? For instance, earlier in the pandemic, we'd used NHS nurses' facilities.
Right.
So what? But there's the question is, where do you isolate people?
Right.
Hence my recommendation now that every care home needs to have isolation facilities.
We'll come back to that.
Yeah. This is the policy row that's going on between essentially between Helen and Simon Stevens, and you'll have to ask Helen about the details of it, because Helen is so competent and such a good minister. I delegated a lot of responsibility to her because she was highly competent.
All right, thank you. Now, if we just go on, that helps us contextualise the two sides of the debate, if you like. Can we go to the 14th of April and page 3 of...
Hold on. Can we just stick on this one? Because actually
Yes.
the remainder of this page is also extremely important in this context.
Yes.
Right. Firstly, who is speaking for NHSE here? Answer, Ian Dodge. And Ian Dodge, in my experience, never did anything without Simon Stevens' sign-off. And then I say, can you please write your preferred language into the document, taking into account genuine NHS concerns, and we will take that forward. So my instruction was that Helen should take into account genuine NHS concerns, but obviously I knew she was also deeply concerned about the care sector, because that was her primary responsibility. And then I said, and we will take that forward. Right. I also know that at the same time that evening, I was having a text exchange with Simon Stevens when he came to me and said, this isn't agreed. I'd agreed some policies with Ros, and Ros said she would handle Helen Whately. And that implies that that they thought they could present an answer to Helen. She's clearly unhappy with the answer, and I am backing Helen.
Right.
And then there was I was also working on a whole load of other things, and when we came back to it, in the end, we did not have the text that Helen had signed off. It was a messy battle.
Right. So there is Helen at this stage, as I understand it, advocating for the quarantining to take place, perhaps not in a hospital, but under the umbrella of the NHS. And the NHS are saying they don't want that. Mm-hmm. There are the machinations behind the scenes that you've just spoken of.
Yeah.
But can I turn to the 14th of April, please, to round off this exchange?
Yeah.
Because by 10 o'clock the next morning, if we see there the message at 10:07 from Helen Waitley. She says, for discharges, I concluded last night it does make sense for local authorities to have responsibility for people who don't need to be in hospital but do need to be quarantined.
Yeah.
My understanding is the LGA and ADAS agree, and the NHS clearly. It can be funded out of the 1.3 billion that went to NHS for discharges. The question is one of how do they do it, e.g. by commissioning a specific care home for the area or hotel accommodation. Some already doing this. She says that I realise you may disagree and want to revert to NHS. And then you say at 11:27, I'm very happy for it to be via the local authorities.
And then I say, obviously consider it for 7.5 minutes, and then say, best to include in wording on discharge as agreed locally between the NHS and local authorities. I'm trying to get to a joint position.
Right. So then,
in the working, anybody who's worked in this area knows that the communication and the co-working between the NHS and local authorities in terms of discharge in all normal times, it is extremely difficult. In some areas it works well, in other areas it works badly. It is a very, very complicated intersection, and anybody who's had a family member, maybe a parent, who's had to go from hospital into a local authority setting knows that getting the funding package for that is a real nightmare. So this is a standard problem in a much, much, much worse context.
all right. But what I wanted to ask you, Mr. Hancock, was when you said I'm very happy for it to be via the local authorities, why did you plump for that side of the coin as opposed for it to being quarantining on the NHS side of the coin?
Because I'm taking Helen's advice. So my two key people here are Helen and Simon Stevens.
Right.
And Helen obviously advised by Ros. Helen has overnight essentially considered the NHS option further, as I'd asked her to do on the previous page. I'd said write into the document what you want, taking into account the NHS's real world concerns. She's then come back to me the next morning to say, as she says, I've concluded last night that it does make sense for local authorities. So in my view, if she's come to that view, essentially representing internally the view of the care sector, right, and she's agreed it with Simon Stevens or his delegates, then I am content with that outcome. That was in this area where you have two extremely competent people in Helen and Simon, and if they agree on a policy, I would have to feel very strongly to then overrule it.
Okay.
But as you can see, I then add a sort of coda to it, which is, please, can everybody work together, essentially?
No, that's fine. So, and in due course, it was the local authorities who were to be responsible if they couldn't isolate in the care home, providing an alternative setting or an arrangement for care homes where there weren't isolation facilities, and that was written into the action plan.
Right.
So that's where we get to.
Yes.
Do I take it from everything that you have said this morning that you consider that the discharge policy should have advised isolation from the get-go?
If that had been available, yes.
Right.
But it wasn't. So it depends. So it would have been. It wouldn't have worked to advise that where isolation hadn't been available. It comes back to preparation, and it comes back to the doctrine.
I tell you why I ask it in that way, because you've commended to her ladyship the need potentially in future for all care homes to have isolation facilities.
Yes, I haven't recommended that potentially. I've said it absolutely, but yes.
No.
100%.
But taking that to be something that you feel strongly about,
yes,
Mr. Hancock, back in March 2020, is it the position that you didn't know which care homes did or didn't have isolation
that's correct,
facilities?
Yeah.
All right.
And they would have been up to we wouldn't have known the standard of isolation either. So, for instance, later, in the second wave, when we did require isolation, we then got the CQC to go around all the care homes to check how high quality the isolation procedures were. And that's the sort of thing that needs to happen in peacetime now as well.
Right. May I ask you, though, given the varying size of the care homes, from small providers with 5 or 6 beds to 50, 80 bed care homes, how realistic is it, in your view, for every care home to have an isolation policy, given the huge diversity of the size of care homes?
I would make it a requirement, and of course it will have a cost attached, but preparing pandemic preparation has a cost attached. And we've talked before about how I think it's ludicrous how little money has been put into pandemic preparedness. You know, even in the latest spending review, the UXA budget is radically underfunded. It is a dereliction of duty of the government to put so little money into pandemic preparedness. This is just another element of pandemic preparedness. You know, we're talking about radically increasing the amount of money we're spending on physical defence, but bio-defence is as important and gets 1/100th of the resources of the state. It's an enormous ongoing failure that is getting worse, not better.
All right. We know in due course by the winter of 2020 going into 2021, there was a designated settings policy, which required, I think, at least every local authority to have at least one care home where they could take discharges of COVID-positive patients.
Yes, and I think this was a response to precisely the point you just made, which is that there may be some, especially small care homes, where an isolation facility is not possible. Remember, an isolation facility could still be used when there's no outbreak as a bedroom. It's just that you need the ability to then create isolation areas where when the need comes. And this should be used for flu as well. I mean, flu. We have an epidemic every winter in care homes, so there is no excuse to be waiting.
Right. The question I wanted to ask you there about the designated settings policies, you said in your statement it would not have been practicable to take this step at an earlier stage of the pandemic.
Yeah.
Can you help us, please, with why it was not practical?
Oh, for the reasons that you set out, that there are many different care homes, some of which would have been able to do it, but others wouldn't.
Right. One of the other measures that was taken back in March 2020 was to buy capacity from the independent sector, the private hospitals.
Yes.
And indeed, you will know from Module 3 and your experience, there was the 3-month pause on elective surgery to free up bed capacity.
Yeah.
I think somewhere around 20 to 30,000 beds potentially freed up. Do you think it was possible to have delayed the expedited discharges until such time as the 15th of April, when testing was available, by using the spare beds that had come from the cessation of elective care, or the spare beds that had been bought from the private sector?
No, it would have been better if that had been a credible option, but it wasn't.
Can you help us with why?
Yes, the reason is very straightforward, unfortunately, and clear in the data, which is that we ran out of NHS capacity. If we hadn't built the Nightingales, we would have had hundreds of people without the ability to be treated. The Nightingale, the XL London Nightingale Hospital. Even having taken the policy of discharge, we still didn't have enough NHS capacity. So it's just a matter of fact that the NHS became full, and thankfully we had the Nightingale capacity. Not nearly all of the Nightingale capacity was used, but some was, and that which demonstrates that there wasn't that spare capacity, even having done the discharges.
Of course, a number of people discharged from hospital were discharged back to their own homes.
Yes, in fact,
Most.
far more than went to care homes, yeah.
Yeah. Did you consider the impact on the reduction of access to care and the early discharge of patients on those and their family carers who are doing their best to try and look after their loved ones?
Yes.
Can you help us, please, with what was done to provide support to the unpaid carers that were looking after people that went back to their own homes?
Yes, so the primary response to that problem was the shielding programme.
Right.
And we've considered that in other modules. I regard it as one of the big successes. It was designed essentially by Jenny Harries at a clinical level, and it was and then others, including from the private sector, came in to make it work.
You set out in your statement your overall reflections on the appropriateness of the discharge policy. And does it come to this, Mr. Hancock? There was no good decision from your perspective, and you consider the hospital discharge policy to be the least worst decision?
Yes.
All right. You say in your statement, can I have up on screen, please, 0030 of Mr. Hancock's statement and paragraph 129. Excuse me. Yes, thank you very much. I want to look at the practical effect or otherwise of the discharge policy. And you say in your statement there, a widespread concern was that patients who were being discharged from hospital were the main source of infection in care homes. I understand why many held this view. However, we now know this was not the case.
Yeah.
We learned in the summer of 2020 that staff movement between care homes was the main source of transmission. As I will later discuss, we acted on this and we asked for urgent work to be undertaken to restrict such movements. And we're going to look at staff movement in a moment. But your reference there to the learning in the summer 2020, can you help us now with what study or research or report it was that that sentence is based on?
Well, as we've seen in the discussion this morning so far, we were worried about issues relating to staff from March, and a number of different pieces of evidence were brought to bear, and ultimately it was a PHE. It came from PHE that staff movement was likely the main source of transmission. Once you have taken the position that asymptomatic transmission is significant, then it becomes more intuitive that staff movement and indeed visitors are likely to be the main source of infection, simply because there are far more entries into a care home by members of staff than by residents.
So your recollection is it was a PHE study that is essentially being referred to when you say we learned in the summer of 2020?
Yes, the reason I phrase it like that is because I don't know the precise source of where that became, where that insight came from.
Right.
I know that it wasn't my insight. What I know is that once I saw that was, once I saw that evidence, I seized on it and tried to change policy on the basis of it, and that carried on for the rest of the year. But sometimes anyway, I don't know where it came from exactly, but somebody spotted this.
Let me see if this helps you at all. Please say if it doesn't. Were you aware of the findings of the Vivaldi study that started to emerge in June of 2020?
Well, Vivaldi was one source of this, but I wouldn't stress the Vivaldi study. SAGE, for instance, considered a very wide range of scientific advice in this space, and including but not limited to Vivaldi.
If given some time, would you be able to find the PHE study that you're referring to in the summer of 2020?
I'm very happy to write to the inquiry with more detail if I can find it.
Please do. I ask you that because we're aware of a study that they did in July 2021.
Oh, sure, yeah.
Which is a long time after this.
No, I know the 2021 study, but that is obviously an analytical and backward-looking. What I can't remember is who came up with the point that staff movement is likely to be a problem, and therefore we need to do something about it. What I remember is that once that penny dropped, we got onto it.
Can I ask you this? You say there that we learned in the summer of 2020 staff movement was the main source of transmission.
Yeah.
Vivaldi says it was a source of transmission, not the main source of transmission. Are you able to help us now with what it was that led you to believe it was the main source of transmission as opposed to a source?
Well, as I said, I'll have to write to you with that exactly. We know that it's the main source from all the scientific work that's been done since. I would not put the stress on Vivaldi as a sole source of truth on this. It was a helpful but not the only piece of scientific work in this space.
All right, there have been subsequently a number of studies, a PHE report from July 2021,
Yeah.
a consensus statement in May 2022. But can I just, before we have to descend to the detail, if we do, I take it you are not suggesting that the discharges did not cause some infections in care homes?
No, of course. The word main is critical here. You know, the 2021 PHE study suggests that the percentage is under 2%.
Yes.
You know, you
Well,
want that down
can
to
I help you
zero,
then?
right? You want to get it down to zero. The aim here is
pause.
to as much protection as possible.
Let me help you by calling up the PHC study so that everyone else can follow what we're talking about. INQ, please, 234332_3. This is a PHE report dated July 2021. I think, in fact, you had resigned on the 26th of June of 2021. But here's the published report. And as you say, PHE set out there that, in fact, it was 1.6% of outbreaks of the tests that they had conducted were identified as potentially seeded from hospital-associated COVID-19 infection, with 804 care home residents with confirmed infection associated with these outbreaks. The majority of these potentially hospital-seeded outbreaks were identified in March to mid-April 2020, with none identified from the end of July until September, where a few recent cases have emerged. So you're right, the PHE data is suggesting a small proportion of patients discharged from hospital accounted for care home outbreaks. But do we not have to factor into that, Mr. Hancock, that there was limited testing up until the 15th of April?
Yes, but there was also limited testing from everywhere. So that applied, the limited testing applied across the board. So it doesn't invalidate this finding. My point here is not, I don't have any additional scientific input into this question. It's an important question. I have what I'm stating in my witness statement is based on the best scientific evidence available. What is the assessment here? In a way, my policy point, and that what matters now, is that staff movement is a major issue for a novel pathogen, especially one where there's asymptomatic transmission. And indeed, some say that since care home workers sometimes are also bank workers in hospitals, then you should take that into consideration, because there's a potential spread there too as well in the ban on working in multiple places that I recommend. So, you know, that's the point.
Can I just ask you, before we leave this page, clearly the conclusion in the exec summary is the findings of the report suggest hospital-associated seeding accounted for a small proportion of all care home outbreaks. The policies on systematic testing prior to hospital discharge for patients discharged to care home, and where a test result was still awaiting, the patient would be discharged pending the result isolated, were introduced on the 15th of April. This may have supported the decline seen in these outbreaks, contributing to an overall reduction in care home cases.
Yeah.
So that essentially is supporting the need for pre-discharge testing. Would you agree?
Absolutely, but you've got to remember there was no tests.
No.
Yeah.
No. The absence of tests, though, in March to mid-April,
Yeah.
do you agree, does make it difficult to reliably assess the extent to which the discharges caused infections in care homes?
It makes, yes, and absolutely, it makes it difficult to assess all of these things. You know, we were working in an environment of low and unreliable data. Of course, we were. Hence, why the acceleration of testing capacity was so important, which we were doing at the same time. So yes, that all these things are true. You know, in fact, even in this study, 1.6 is what was measured in this report, but it does seem to me, you know, a spurious level of accuracy. The 0.6, but what it's saying is it's relatively low in this report. What the policy consequence of this is to ask where is the 98% coming from, but also at a human level, 1.6 is still too high, right? It may only be 1.6%, but if the impact of that is that one of your relatives dies in a care home, as one of mine did, it matters.
Yeah. Well, that's why I want to come on to staff movement between care homes, please. A number of the documents that we have looked at, indeed that you will have seen, Mr. Hancock, comment on the unintentional infections caused by staff movement. And indeed, the CMO's technical report, as I think you are aware, and indeed you quoted it in your statement, makes the point that the majority of outbreaks were introduced unintentionally by staff members living in the wider community. Interventions to mitigate this through asymptomatic testing and the avoidance of cross-deployment were only partially successful at times of high community prevalence.
Yes.
That's what the 4 CMOs wrote up.
Yeah.
Do you agree that in reality, the 3 main routes of transmission into the care homes are either staff, the visitors, or the admissions themselves?
Yes.
And I want to just look at the staff transmission route. And could we have up on screen, please, a COVID strategy meeting on the 6th of May, INQ 146701. Now, Mr. Hancock, this was I think it's sometimes called a deep dive.
Yes, could you remind me the date of
Yes, 6th of May. Now, you're not present.
Okay.
Helen Waitley is. The meeting was about care home delivery plan and, for what it's worth, nosocomial infection rates, all right? But I just want to ask you about some of the things that are said in the deep dive. At that strategy meeting, the Director General, so Ros Wharton at the time, said that DHSC had worked with care providers to identify several measures aimed at reducing the spread of infections in care homes. One measure proposed would be to restrict the movement of staff between care homes. However, this had presented some key implementation challenges for care providers.
Yeah.
She said the care providers needed a larger workforce pool to ensure they had the capacity to restrict intra-care home movement. She said that some staff were concerned about the financial consequences of restricting shifts to one care home, and many staff would not be willing to work this way. And she said further work was needed to understand the funding consequences and the resource requirements to implement the proposal. And so she's made the attendees of the deep dive aware of the challenges here with limiting staff movement.
Yeah.
Although you weren't in that meeting, you're familiar with those challenges, no doubt, Mr. Hancock.
Yeah, of course, yeah.
And do you think it was therefore known at an early stage that mandating restrictions on staff was not really going to work without either a larger workforce pool and or financial consequences to try and compensate those who are now having to limit the way in which they work?
Yes, and I think I articulated this at the time. I've seen that in the paperwork. The conclusion we came to, which I announced on the 15th of May, was strongly to recommend. But then, and that did reduce the infections in care homes, and in the second wave, the problems in care homes were much, much lower. What I would say, though, was that having brought that, I think we ended up with about a 90% reduction in staff movement, i.e. the number of staff in the system working in more than one care setting. I then, over the autumn, tried to drive that to zero with a mandated solution and couldn't get that through.
We're going to look at that.
Okay.
Right. There's one thing I wanted to ask you before we come to the autumn efforts.
Yeah.
Can we see lower down the page, reference to the first Secretary of State, Mr. Raab, said that care homes were a decentralised system. A recommendation should go to the Prime Minister on the government mandating the restriction of movement of care home workers in between care homes for 1 month.
Right.
Subject to legal consideration. Now, bearing in mind you weren't in it, though, were you aware that there was a potential for a 1 month trial period or pilot, call it what you will, to restrict movement?
Yes, I would have been. I expect that I would have been debriefed on this meeting by Helen. As you could see, our relationship was very good, and also I would have seen these minutes.
Yeah.
I would have just not been able to go to the meeting because I would have been doing something else.
We're not aware that the 1 month pilot or trial, call it what you will, in fact happened.
Right.
Are you aware whether there was such a pilot?
No, I don't recall it being getting anywhere. Not least because it says here, subject to legal consideration, and as we'll see when we go through the autumn, the legal considerations were significant.
Yes. Now, I don't want you or anyone else to be confused. There were clearly, when you were thinking about mandating restrictions on staff movement, legal considerations, but were you aware whether there was a reason why the pilot didn't go ahead?
No.
Okay. All right. Following, I think, that meeting, I think you were considering banning staff, and indeed you wrote to the Prime Minister.
Yeah.
And I'd just like to have a look at the letter, please. INQ 292617.
Do we have a date for this?
Yes, it was the 8th of May.
Right, okay.
All right, so just a couple of days after the deep dive. All right. And just forgive me one moment, I just need to call up. My document. We can see there it relates to the care homes and nosocomial transmission. You say, following the deep dive, the letter sets out the department's plans.
Yeah.
You've got their reference to the latest Public Health England evidence showing that there is asymptomatic transmission via both residents and staff. It's similar to transmission in the community. And you set out the 5 steps. And if we could just go down to paragraph 4, thank you. You say, at its heart, the core of the problem of managing social care is that accountability for delivery falls to us, while the levers are held by the local authorities, as we touched on this morning. This makes delivery of sensible policy proposals like reducing staff movements between providers very difficult. We need to change this through legislation.
That has not yet happened.
No, just bear with me because we will get there.
Yeah.
But in the meantime, the most effective way we can drive specific policy directly is to tie adherence to funding, to give funding to those providers who act in the correct way.
Right.
Now, pausing there, a number of questions that flow from that. Can you help us with why there was no legislation immediately proposed in May of 2020, given that you are fully alive to the problem of staff movement?
The decision that was taken was to go for a non-legislative recommendation. Getting legislation through takes time. And we were putting through a huge amount of emergency legislation, mostly relating to lockdown measures, and so getting legislation through would have been a serious consideration. And remember, at this point, we are all exceptionally busy. Therefore, in the meantime, being able to put out a piece of guidance was a good way of getting started on this, and so we did on the 15th, and it made a big impact. But I didn't let go of the need to then drive this further, although that never happened.
All right.
In a way, why I didn't go for legislation at this point is demonstrated by the fact that I then worked until Christmas to try to get legislation, whereas standing up at this press conference and saying, please stop movement as a recommendation, we could enact only 9 days after this advice to the PM.
All right, and I just wanted to look at one other paragraph over the page, please, on page 2. You say there to the Prime Minister, paragraph 10, please. Just a little, thank you very much. As we are looking to compensate workers for the financial impact of restricting where they can work, I am strongly of the view that we must ensure that those social care staff that need to isolate do so on full pay rather than on statutory sick pay. To date, we've been encouraging providers to adopt this policy wherever possible. However, we know that many are not, citing that local authorities have not passed on the funding, which we announced in March, a large proportion of which was intended for this person. And then you say you'd like to be more directive. So, as I understand it, here you are pushing for recompense.
Yeah.
But help us with the section that says, to date, we've been encouraging providers to adopt this policy. However, we know that many are not,
Yeah.
citing that local authorities have not passed on the funding. What ability did DHSC have to ensure that local authorities did pass on the funding in accordance with the intention?
DHSC had no levers over that.
Right.
In a way, this paragraph and the previous paragraph absolutely reflect the discussion we've already had. I mean, I'm a bit like a broken record on statutory sick pay, I didn't know. I haven't seen this document in preparation for this session, but it's safe to say that my views remain the same today.
And so on the 15th of May, there was guidance which asked, essentially, care homes to ensure that members of staff only work in one care home wherever possible. This includes staff who work for one employer across several homes, or members of staff that work on part-time basis for multiple employers.
Yep.
And I think on that day, you indeed announced the Infection Control Fund.
Yes.
Which was deliberately designed to try and recompense workers who were having to limit their movement. It had other functions as well, don't misunderstand me, but that was one of the main aims of the fund, was it not?
Yes, without, yes. What you can see from that combination of things, the fund, the purpose of the fund, the innovative use of the fund to require behaviour changes on the ground, the limitations to staff movement, I hope you can understand what I was trying to communicate when I summed that up with the piece of rhetoric that we discussed before the break. We felt like we were doing everything we possibly could to support. That is how it felt. We were really leaning into this problem, and hence I used a form of words that subsequently has been. I've been criticised for, but in a way, the discussion we've just had demonstrates the huge amount of work and consideration we were putting into how to try to continue to improve things on the ground.
Right. Now, you said that the fund itself and indeed the guidance resulted in 90% of care homes acting to restrict staff, and you say in your statement, we wanted to go even further than that and reduce staff movement to zero.
Yes.
Right. And I'd like to ask you, please, about just some of the things you did over the autumn of 2020 to try and bring in the legislation. And could I just have a look at a few documents with you, please, Mr. Hancock? Can we have up on screen, please, INQ 233987? This is the 14th of September. And there's a paper that is, there are a number of papers over that autumn on this topic, but you say the paper's not strong enough. We need to propose the rule that working in more than one social care setting is illegal under public health law. Likewise, we need to mandate self-isolation for social care staff and make the care home responsible for that. Were you taking legal advice at this stage about bringing in a new law or amending an old law? Can you help?
I think that the reference to under public health law means my goal here is to use the existing legislation to find a legislative hook, if you like, that could be used based on because there's a number of very strong powers in the 1984 Act that allow a wide degree of discretion for policy if it is based on the advice of clinical advisors. And this is where I've got to in terms of legislation. Instead of new legislation, I'm trying to use the existing legislation. I would have thought it would require a statutory instrument under the 1984 Act.
Yeah, and I think in due course you received advice about amending various regulations that were in place as a potential way of bringing in this law. But I don't want to get into a legal...
It's second order.
Yeah. Can I ask you about this, though? Likewise, we need to mandate self-isolation for social care staff and make the care home responsible for that. What did you mean when you said you wanted to make the care home responsible for mandating self-isolation?
I'm not exactly sure.
All right.
As in, I can't remember now the mechanism that was in my mind when I wrote this.
Putting the mechanism aside, can you help us with why you wanted it to be the care home's responsibility?
Because they're on the ground, they'll know who does and doesn't need to self-isolate. And you can't decide individually who's ill and who's not from, or who's got a positive test from Whitehall. That has to be an on-the-ground decision.
I want to jump. There was various COVID-O meetings about this topic. Can I ask you, please, just about one of them? Can we have up on screen, please, INQ 90180 underscore page 4, please? You were present at this meeting, Mr. Hancock, which was on the 15th of September. And a little bit lower down that page, please. Can we see the sentence that begins, "More could be demanded of the sector"? Let's just pause there. I'll just wait for it to be highlighted, Mr. Hancock. But there's a sentence, I hope you've got it.
Yeah.
Some of the recommendations would be uncomfortable for the social care sector. More could be demanded of the sector. The measures include strengthened CQC inspection regime and legal powers to prevent staff movement, require full payment of wages when isolating, stop visiting, comply with PPE, and a number of things. Government should consider going stronger on staff movement restrictions and sick pay in particular, and legal powers to enforce these would not face the same backlash that had been seen earlier in the year due to the existing guidance. Can you help me with that reference? What was the backlash that was being referred to there?
I don't know. You'll have to ask Helen.
All right. She says this was a stick that needed to be accompanied by the incentivising carrot of additional funding through the ICF. A further stick to consider was a move to greater transparency through publishing care home test rates.
Yeah.
Can I go to page 7 of that document? Because it then sets out a number of things that were discussed in the meeting. And I wonder if you could help us with J there. In the course of the discussion, there was reference to the sector had not done enough to protect those in its care, nor its staff.
So maybe
Can I ask the question?
Yeah, of course.
Thank you. Can you help us, please, with what that was a reference to?
Yes, of course. The best way I can describe this and answer that question is to explain what these points are in Cabinet Subcommittee minutes, which this is an example of. What happens is that the chair and the main policy holders set out their position, or the paper, for instance, that you're discussing, and that's the block of text we were looking at a moment ago was Helen setting all that out. It demonstrates, by the way, the degree of confidence I had in my junior minister that she was the one giving the presentation rather than me. That is not normal in these situations. Then there is a discussion around the table, including with the ministers who come from policy areas not responsible for this, and they are those comments without the name of the minister are put in these, and this is cabinet papers are all the same like this as well. So what this means is a minister present, but not the chair, not Helen, and not me, because we would have our names put against it, has said the sector hasn't done enough to protect those in its care nor its staff. I've no idea who said that or what he or she meant by it. You often get, how shall I put it, broader considerations brought to bear in these comments.
Right, but that certainly should not be taken to be either you or the minister.
No, it is definitely not either of us.
All right, but can I ask you this? If you didn't agree with that, and you clearly don't, Mr. Hancock, can you help with why the notes don't say Minister or Secretary of State said that's simply not
because
right?
if in cabinet subcommittees like this you rebutted every point you disagreed with, you'd be there for a long time. What you do is they normally come to you at the end. You respond across the board, and then the chair sums up. And the summing up of the chair is the policy of the government. In this case, Michael Gove was in the chair. He strongly agreed with Helen and I, and generally, as an overall approach, And I haven't seen the summing up, but those areas, those minutes are normally more crisp and more action-oriented, because that's the bit that turns into policy.
In due course, in response, you made a number of observations about the ICF, and you said regulations on staff movement would require careful exemptions, for example, GPs that serve more than one care home. But I just wanted you to contextualise that so people didn't misunderstand that comment. Now, to come back to where we were, you wanted a policy essentially, therefore, of zero staff transfer, as I understand it. You were seeking...
Yes, with as you that would end up being it would end up being slightly more complicated than that, but that was the thrust of it.
Right. You had sought legal advice as whether that you could change existing legislation to mandate that.
Yes.
And in due course, you wanted to provide money for staff who would not be able to work so many hours if they could only work in one care home.
Yes.
And indeed, I think you brought that up with the Treasury.
Yes.
And were you able to secure funding to achieve your aim?
No.
Right. Equally, it was not possible to legislate to bring in such a ban, was it?
It was possible. I was not authorised to do so. It was perfectly
It may
possible.
be my misunderstanding. No, you're quite right. You said you finally accepted on the 7th of January a full ban would not be possible. It was because of opposition from key system players, particularly in light of the vaccine. And some of the opposition was that there was a concern there wouldn't be enough care staff to provide good quality care.
Yes, I didn't think that consideration merited much confidence, given that we'd reduced staff movement from by 90% over the summer, and it hadn't had that consequence. Going the final 10% was also not going to have that consequence. The dates here are instructive. The papers we've just been looking at are from September.
Yep.
I then fought a battle that autumn to get this put into place. In fact, I had dates of announcement of this policy agreed a number of times over that autumn, and there was a rearguard battle somewhere in government to stop it happening. And in the end, I got the go-ahead that I could launch it if we compensated people and I could secure funding from the Treasury. But since the Treasury are the unilateral decision makers on funding, and they said no, that was effectively a killer blocker. I still to this day don't know who stopped this policy from happening. But as you know from earlier modules, there are a number of people who are prepared to use all sorts of tactics to try to stop things that I thought were necessary to save lives. And, sometimes that boils up and sometimes it's done quietly.
You obviously, it's set out in your statement, I'm not going to go through it all, made a number of efforts to try and bring this legislation in, if at all possible, or at the very least to find some way of restricting staff movement. And do I take it that you think that that is something that should happen in non-pandemic times? Yes,
I do, because of the number of deaths in care homes from flu and other infectious diseases, yes.
Do you think it is a matter that should be brought in via legislation?
Yes, and I think in normal times you could do it in a very considered way, thinking about the exemptions that you might need, the levers that you'd use, and the enforcement mechanisms that you'd put in place.
Is it possible, forgive me, is it possible when you have a very limited workforce?
Well, we don't have a limited workforce. There's 2.5 million people, and we managed to bring this in with 90% effectiveness without causing there was more pressure, but it's not a disruptive negative consequence on the workforce. So it's absolutely doable. And it comes down to, in a way, the cost of looking after people in care homes. Do we think that it's right that we allow people to go to work in a care home with the flu, knowing that may well spread the flu to people in care homes?
I'm not questioning the wisdom of the policy. I'm just questioning whether it's practical. I thought I heard 100,000.
Yes, may I pick up on that, my lady, and to help you, Mr. Hancock. There was a DHSE briefing in November that estimated that 22,500 staff in residential care held a second job in social care.
Yeah.
And the majority are understood to hold two jobs, perhaps one in residential care and one in a domiciliary care setting, for example.
Yeah.
There are also, I think, about over 1.5 million jobs on 0 hours contracts.
Yeah.
And so, to pick up on her ladyship's questioning, how feasible or realistic is it to ban staff movement when people are relying on having 2 jobs?
It's a perfectly reasonable question, but I think that it's entirely feasible, because you could easily rejig the employment arrangements so that if 2 care homes each employ people part-time, and then each of them could take a fewer number of people full-time. It would lead to a decrease in flexibility, that's absolutely true, but you could still work in one care home on a 0 hours contract and do something else when there weren't any hours coming from that care home, for instance. But why should we have care home workers on 0 hours contracts anyway? Don't people in care homes deserve highly professional, highly organised with support with staff who are in reliable employment? I think it's a sort of we should be more ambitious for the care we give to the most vulnerable in society.
Same topic from a slightly different angle. Were there ever any plans to try and restrict staff movement in domiciliary care?
No, I don't recall that. Domiciliary care is different because you're by your nature in the community all the time. So, it doesn't, in a way, if you worked for 2 different employers in domiciliary care, you'd still be visiting dozens of different houses to look after the clients, no matter who was paying the bill.
It brings me on to, I want to ask you about domiciliary care, because clearly there would be real practical difficulties with restricting staff movement in domiciliary care for the reasons you've just given.
But also it'd be less important. Because,
why would it be less important?
Well, say you're a domiciliary care worker who looks after 15 people and you go into their home. If you did that for one company, you'd still be visiting the 15 people in their homes. If you did it for 2 companies, you'd be visiting 15 people just being paid through 2 different companies. It wouldn't make a difference to the spread, to the clinical outcome. So it's less important. Whereas a care home is a physical setting that where infection can occur within the setting.
Yes. Although a domiciliary care worker going from house to house to house, providing close contact, is equally providing care in a close setting.
Yes, but what you'd have to make it work, you'd have to say that domiciliary care workers could only work with one person or a smaller number of people, and that would probably be impractical.
Okay. In relation to domiciliary care, though, given that on any view workers had to move from house to house to house, and acknowledging as you do, you can't restrict their movement, and you can't isolate the person in the house because the carer has to provide the care, the washing and the like. Can you help us then, please, with what was done in relation to PPE for people providing domiciliary care? Yes,
well, we provided PPE to domiciliary care workers, but again, in non-pandemic times, that is the duty of the company involved. They're not all companies, but nearly all domiciliary care is provided by the private sector. And we provided free PPE. It is a less defined sector by its nature, and so it's harder to be absolute about how many people, what proportion of people benefited from that.
All right. I want to look at some of the efforts to provide free PPE that were taken up during the course of the pandemic, particularly at the beginning. Now, you've made the point, obviously, that formal responsibility for PPE distribution rests with the individual institutions and care homes. And prior to the pandemic, the NHS supply chain only supplied the main hospitals. Whereas, of course, in social care, they provided PPE for themselves. Right? Just to provide the context for everyone. And on the 13th of March, there were 7.5 million masks delivered to the 25,000 odd care homes in England. All right, that amounted to about 300 face masks per CQC registered provider. And I think you chastised me earlier for laughing at you, and I certainly wasn't. But I'm asked to ask you why so little PPE was provided to that number of care homes when it amounts to, Mr. Hancock, 300 face masks per care home, which will be gone through in no time.
Well, that was just the start of it. And obviously we built up that PPE supply. But the PPE was in incredibly short supply globally. We've had a whole module on it. So the substantive answer to the substantive question is that we did everything that we could and went the extra mile to get as much PPE as we possibly could in the circumstances.
Does it come to this, that's all you could afford to give at the time?
It wasn't about affordability, no.
No, but that's all that was available.
That's all the resources that were available at the time, given the clinical prioritisation of PPE into hospitals.
Now, there was a further drop of PPE to the local resilience fora in April, and I think you were informed of the plan by way of a submission. And can we have a look at that, please? At INQ 551 555. This went to you on the 4th of April. It was an emergency PPE drop to the 38 local resilience fora. Are you able to help us with the background as to why there was this need for an emergency drop at the beginning of April 2020?
Because there was a shortage of PPE. I mean, we knew that from March. The challenge was getting as much PPE as possible. And we also were trying to invent a distribution system as well, because in some cases the private sector distribution system worked, in other cases it didn't.
All right. You've arranged, you can see there, DHSC have arranged a one-off drop of PPE to each local resilience forum in England to help respond to local spikes in need and blockages in the supply chain.
Yeah. So, in some of the many criticisms about what happened with PPE, sometimes people say, we had to go outside the government system and got PPE. Well, we regarded that as a good thing. If you could get your hands on PPE through private procurement or through your own efforts, then of course that's good. It was all shoulders to the wheel. This was the additional PPE that we could direct from the centre to go into this space.
But this PPE was not solely for the adult social care sector, was it? It included prisons and any other enclosed setting that the local authority felt there was a need for PPE.
Yes, that was a matter for the LRF to decide the...
OK, but I don't want anyone to misunderstand this was a solely social care-related emergency drop.
No, I think I describe it as a primarily social care-related emergency drop, yeah.
The highlighted section there says in the final sentence, we do not expect that NHS acute trusts or ambulance trusts will need to draw from this supply, given they're already being supplied via the NHS.
Correct.
Were you aware that PPE supplies for NHS were being prioritised at the expense of the adult social care sector?
That was not my assessment of it. There was a clinical prioritisation, and that was based on advice. It wasn't something I would interfere with. I'm absolutely aware that that people, for instance, some people in LRFs felt that there was a prioritisation and that the NHS hoarded PPE. I didn't ever find evidence of that happening. What I found evidence of was in a situation of desperately short supply, everyone was trying to get their hands on PPE, and if they got their hands on PPE, they would tend to hold on to it. So I don't ascribe any negative intent on some of these behaviours and accusations that we've seen in this space. I totally understand why people complain about it, but at the same time, this was a desperate situation in terms of PPE supply.
All right. Can I ask you about an email chain that has been provided to you, please? Can we have up on screen INQ 572355? You're not copied into it, but I want to know if issues like this came to your attention. This is an email chain between the National Care Forum and people at the Department of Health. And could we go to page 4, please? The National Care Forum are setting out to the department a number of concerns they've got but they, in the course of the email, make reference to NHS requisitioning stock. This is to help you, the 1st of April.
Yeah. So
Mr. Hancock.
I suppose this is an example. I didn't know you were going to bring this up, but this is an example of what I was saying, which is that requisitioning is the wrong word. The requisitioning means mandating taking something. What was happening was the NHS were also buying, and in some cases they would be bidding against each other, out with the government effort to provide PPE.
I take your point. There was never any directive, was there, from DHSC to say that the NHS should get PPE first?
Should be able to buy,
Yeah.
and others not allowed to buy it. That wasn't how it worked.
No.
But having said that, I'm not defending the system. I'm describing the system, and what the truth is, a lot of people felt like this.
Right. Forget the use of the word requisitioning. Can we just look at the examples that are given by the NCF? They told the department that many of the members reported that their suppliers have stopped delivering PPE to them or have had their deliveries diverted to the NHS.
Yeah.
Seems that the NHS supply chain is requisitioning their word, any supplies left. And then there's some quotes.
Yes, I understand.
When we tried to place our orders with our usual suppliers for sanitisers and some other products, we were told they weren't taking orders because everything has been requisitioned for the NHS.
Yeah.
Next quote, our suppliers have told us that all 4 major manufacturers, wholesalers, have been barred from supplying to anyone but the NHS. And indeed, at the bottom there, a number of items, thermometers are completely unavailable. These crucial pieces of equipment for services which remain open have potential drop-in sales. The bottom line is Google has become our procurement source.
So this is absolutely the lived experience.
Right.
And what I'd say about it is, on the last point, the bottom line is that Google has become our procurement source. If Google can provide you a thermometer and you need a thermometer, in a crisis, that's okay. It's less bad than not getting a thermometer. But it's obviously not the best situation. It's not how you'd want it to be. My role in this, if you like, was in trying to ensure that there wasn't overall a national shortage of it, and we've been through that. But this is a totally fair representation that we were aware of this concern at the time.
Right. And so, notwithstanding you're not copied in on this particular email, this does echo and resonate with concerns that you were being made aware of.
Yes, mostly by Helen. I mean, Helen would come to me and tell me these sorts of things. Yeah.
So there are, before the emergency drop to the LRF, there is clearly concern within the sector about their ability to get their hands on PPE.
Absolutely.
All right.
As there was, by the way, across the NHS as well. So, the care felt like this. Some parts of the care system felt like this. The NHS also felt like there were challenges in PPE availability. So it was just that the world suddenly started using PPE at a radically faster rate.
OK, so back to the LRF emergency drop, please.
Yeah.
The plan was to make, I think, over about 30 million items of PPE available to the local resilience for. And I'd like to ask you, please, about an email chain at INQ 325261. And could we go to the final page first? It's on page 3, and then work back to the front of the email. Just to help you, Mr. Hancock, there was a submission on the PPE and explanation about the drop. And then could we go to page 2? This is the comms handling on this drop is below. And can you see the section there's media handling? Given the uncertainty about how this drop will fulfil local demand and the possibility of criticism at a local level, we would not recommend a proactive media approach for this drop, and MHCLG and DHSE will liaise on developing strong reactive Q&A. Was there concern that this was going to be a drop in the ocean, effectively, Mr. Hancock?
I have no idea. I can't recall seeing this.
All right.
I'm not copied into it, but it's a totally, it seems, given the concerns that we were hearing from stakeholders, it's not an unreasonable judgment for a comms official to have made.
All right, but you're going to make an announcement that here we are, we're going to give you 30 million pieces of PPE, but equally, are you acknowledging in that might not be sufficient to help out the sector? Is that how the announcement went?
I've no recollection.
Right. over the page, please, then, to messages, emails that you are copied in on, and we can see you at the top. Hi all, linking in private office subs list. DHC ministers approve the sub and have the following comments. You asked for an annex to be sent, and the ministers said, we would like to be stronger than saying we don't expect acute trusts to supply this. There is already a line for the NHS. Thinks that the letter should include a stipulation that the LRFs do a stock take of their available PPE to give better data to inform future drops. They questioned why there are so many FFP3 masks. I don't need to ask you about this, but you, there at the bottom, agrees with the following feedback. This needs to be pitched. This is a significant drop. LRFs are to use it judiciously as we cannot guarantee when the next drop will be. How does that tally, Mr Hancock, with the comms media handling that we need to be careful because there may be criticism about how and whether
read the next bullet. However, we should not overblow the volumes or overpitch it. So it seems totally reasonable.
Right, but
I'm saying be honest about where we're up to.
Right.
It is, 30 million is a significant number, but we shouldn't overblow the volumes or overpitch it. It seems totally banal.
All right. And did it seem to you to be an acknowledgement that this wasn't really going to be sufficient to help out the adult social care sector, this drop?
I think if I may say so, you're focusing in a little too much on the comms handling of this. Here it says SOS agrees with the following feedback from MHCLG SOS. So what will have happened here is Rob Jemrick will have said, this is my feedback, and I will have read it and just put a tick next to it and moved on to the next thing. This is the comms handling. For me, it was second order. This was as much as we could get our hands on and get out to the system. Of course, it wasn't enough because the world didn't have enough PPE. We didn't have enough PPE. We were out there buying it. And the PPE module has gone into great detail about the lengths we went to buy it. And indeed, a bit like visitor policy, I've been criticised for buying too much and criticised for not buying enough. I
want to deal with one topic, if I may, before we break for lunch, my lady. And it's just this, and it's in relation to use of face masks or coverings in the adult social care sector. Now, Mr Hancock, we know that on the 5th of June, you announced that staff in hospitals should wear face masks and visitors should wear face coverings.
Yeah.
But that policy was not brought in until the 2nd of July in the adult social care sector.
Yeah.
Can you help us with why there was a delay between it coming in hospitals and it being introduced for adult social care?
So the clinical advice was that this was more likely to be an important measure in hospitals, but also it comes back to the very first thing we discussed, which is that in the NHS, we could just make this decision and get on with it. In the world of social care, we had to get cross-government agreement for a decision like this, and it took a whole lot more effort. So I remember very clearly the decision in the NHS. There was a huge toing and froing. You'll remember from the public debate at the time about face masks. There were even some ministers going into shops with face masks on, others not. It was a huge area of contention, and the scientific evidence was extremely conflicting. I then agreed with Simon Stevens and with Ruth May, the chief nurse, that we would require face masks in all NHS settings. We checked that we had broadly enough face masks to do that, and then we agreed it, got number 10 clearance, and I and Ruth announced it at a press conference.
Yeah.
Right. In the NHS, you can just make policy decisions like that because there's a straight up line of accountability from chief nurse recommends to chief executive of NHS, recommends to me, recommends to Prime Minister. 4 people agree. Check it's practical. Done. In social care, decision making just is not like that.
Why help us? Why couldn't you, as a department, say we're bringing this in 2 weeks' time? We're announcing it today, and in 2 weeks' time, everyone going into social care needs to wear a mask.
What's the lever? How could we have? What were we going to do if people didn't?
What were you going to do in the NHS if they didn't do it?
The NHS is a hierarchical organisation. The NHS England put out a circular saying this was going to happen, and that's the decision because you're Your fund. That's how the NHS works, and it was under a centralised system, emergency system, where if NHS England said something was policy, that's what people did.
And if the Secretary of State for Health and Social Care said in 2 weeks' time we're bringing in masks in social care, why would that not have worked, Mr. Hancock?
Because I didn't have this. This is a precise example of not having a lever.
But what lever did you need? Why couldn't you just say it and it be adopted?
A bit like staff movement, I could have said it as a recommendation. However, before saying it as a recommendation, I would have needed MHCLG clearance. I would have needed cross-government clearance, because if a policy affects more than one department, it needs to go to cross-government clearance rather than just be inside the department. It comes back to the very first point we discussed about accountability and levers resting in different places. Essentially, I didn't have any legal authority to say that, and so it took a month to sort it out. But remember, at the same time, the clinical advice was that this was more important in hospitals because of the more acute nature of people's illness in hospitals and frailty, and therefore it was administratively harder to do it in social care, and the clinical advice was saying it's more important in hospitals. So both of those things together explain the difference. But this is just another lesson in how government works, and in some places works better than in others. Where there are straight lines of accountability, things work better, full stop.
There were equally ill and frail and old people in the care homes, Mr. Hancock. And so I'm not sure I follow why you couldn't have said, well, if that's the clinical advice for hospitals, we better do the same in care because they're just as vulnerable.
No, sorry, that's a non sequitur. If the clinical advice is this is more important in hospitals, I can't just say that's not the clinical advice. That was the clinical advice, first. Secondly, I've tried to explain, I'm happy to go through it again, that in government, policy making over social care is harder than policy making over the NHS because of the way it's set up. Because of the fact that local authorities have the contracts, MHCLG has the relationship with the local authorities formally, Treasury has the money, and the Department for Health has the policy accountability, albeit not the levers. This is exactly what I was talking about. This is an example from when we were talking at the start about the lack of levers. I'm not defending that. I think that's a mistake. I think it's an error. I think it needs to change. I wish it had changed already. I was working on changing it when I was in office. It's wrong, okay? But it's the truth.
Okay. It's not the position then that the decision to bring in face masks in social care was because social care was an afterthought?
No, it's not.
Can I ask you, please, before we break, just to look at a WhatsApp exchange, please?
Sorry, can I just ask, before you get it brought on the screen, is the point you're making, Mr. Hancock, that whereas with the NHS you can impose a requirement on the staff, but unless you make it law, you can't impose a requirement on private providers?
You've put it better than me, Chair.
So I just thought it was a short answer.
Yes. There is and hence we brought in requirements in return for getting the emergency cash, because that was like a way to try to short circuit precisely that problem.
Right. Can we have a look at the WhatsApp?
But can I just add one little thing? I'll try to be quick. I totally understand why, if you're in social care, it looks like you're getting things afterwards.
Yeah.
I'm trying to explain why, if you care just as much about each of them, it is still harder to deliver in one space than the other.
I follow that. All right, let's just look at this exchange and then break for lunch. Here we are on the 5th of June, which is the day you announced the mask wearing in hospitals. And you say, can we clear the operational guidance on nosocomial infections, including face coverings in NHS settings? Dido says it can be pulled off by 5 p.m. I presume that's a reference to Dido Harding.
Yes, and 5 p.m. is the press conference.
Is the press conference. And Natasha Price says, Jenny Harries is concerned about this. This announcement doesn't cover the care sector. Yeah. She said it would look bad if it doesn't, and we haven't warmed up the care home stakeholders to it. Ignore the references to Mr. Powis, who was coming to help you announce the...
And Mr. Pearson as well.
Yeah.
Yeah.
But over the page, to page 2, one of your, I
Yeah.
think, advisors says, why are we not saying it for social care? Can't
Yeah.
we say that when social care visitations are relaxed, face coverings will be required? Or have we got some language that shows some, I presume that's some legs, is it?
Some leg, as in language. What I mean, Jamie is an absolutely extraordinary communications professional, and what he means there is language to show that we understand this potential criticism. Because if you go back to the top exchange in this WhatsApp group, it says Jenny Harries. She's a clinical advisor. She is
Yes.
not raising a clinical concern.
No.
She is raising a comms concern. It would look bad. Okay. If we go down again, Jamie is saying, considering that we all recognise that we would get this criticism that you have articulated, he's saying, can't we show, for instance, we will in the future do this in social care, or as he says, when social care visitations, as in visitor policy, are relaxed, face coverings will be required. He wants to demonstrate that we understand this, whilst nobody is challenging the substance of the decision, which is executable in the NHS far more rapidly than it would be.
She says, Jenny's view is that because we haven't spoken to care home stakeholders I probably should be at all, they are likely to be unaware of this and be critical of this rapid expectation. So would advise against announcing today. Could speak to her.
Yes, so she's saying do not announce
Yes.
for social care today.
Yes, because you haven't spoken to the care home stakeholders to prepare them for the announcement.
Yeah, and because there's a whole series of things that you have to do in that sector that you don't have to do in the NHS.
Why weren't they done by the 5th of June?
What? Because we're moving incredibly quickly. These clinical advice on face coverings only changed just before this, and the decision essentially, that question implies that I should have waited within the NHS and done it with social care because of comms concerns. I cared about saving lives. I appreciated that this might cause some criticism, but I cared about the substance and saving lives. And over again in the pandemic, I faced this dilemma. I might get criticised for a decision, but it might save lives. And my decision always was to save lives. It's why I can, I can explain all these decisions that I took, even when there have been broad criticisms of them, and some of them more acute than others. But there are reasons behind them based on the substance, and that's why I get so frustrated when when at other points we have moved off the substance. Here, this is a classic example. I could have delayed, but I thought it was better to keep people alive.
Right, doesn't it imply you should have brought forward the care sector announcement rather than delay the NHS England announcement?
No, it doesn't. Jenny Harries is advising against announcing for care homes.
Yes, and the reason she is because you haven't warmed up the care home stakeholders.
No, because the policy, the clinical advice on wearing face masks has only just changed. So this absolutely supports the decision that I made, because the only alternative. It comes back to this question of when you don't have good alternatives, right? When there aren't good options, it comes back to that. The only alternative that you've suggested is that we delay the NHS announcement. Now, I wasn't prepared to do that. No. And if you say, well, should you have brought forward the care home announcement? Well, I've got Jenny Harries saying don't do that because we're not ready for it, essentially. And I hadn't got cross-government clearance either, so I wouldn't be able to do it. So, and there you are.
I think that's as far as you're going to go.
Yeah. Thank you, my lady.
Otherwise, I'll have a stenographer on strike.
No.
2:10, please.
Thank you, my lady.
All rise.
Mr Carey.
Thank you, my lady. Mr Hancock, can we stick with a few questions, please, about PPE, and then I have a number of other topics to cover with you this afternoon. At paragraph 199 of your statement, I don't need it called up on screen, but you set out there that you received a submission from the PPE demand team at the department on the 15th of July proposing free distribution of PPE to frontline primary and social care services, initially until March 2021. Is that right?
I'm sure it is.
Well, I'm taking it from your statement.
Yeah, of
and
course.
you thereafter extended the free PPE to March 2022.
Right.
Right. Obviously, that postdates, the end date postdates your leaving the department. But can I ask you about unpaid carers, please?
Yes.
And PPE for them. And can I call up on screen, please, INQ 328012_4. Now, this is a submission, in fact, to the Minister.
Right.
I'd like to ask you about a few things in it, if I may. If I ask you something and you can't answer, please, will you let me know? All right. It was a submission to Helen Whately in November of 2020, asking her to amend guidance to advise PPE should be worn by unpaid carers when providing personal care to someone who they do not live with. All right, just to help you. Okay?
Okay.
And can I ask, if the submission goes to the Minister, do I take it that it doesn't come to you?
Correct.
Would you expect, though, a submission like this for her to speak to you about it or to ask your views on it?
No.
All right.
If it's just to her, as opposed to her copying my private office or copying, or to her then me, I'd see it. Otherwise,
Fine.
And especially with a minister who I delegated a lot to.
All right, fine.
Essentially, in government, the civil servants work out which junior ministers the Secretary of State trusts and which one
Right.
he or she doesn't. And in this case, they'll know that I would have agreed with whatever decision she.
And so we shouldn't take this as signifying that you weren't interested in unpaid carers. This was just one of many tasks that you no doubt delegated to Helen Whately.
Precisely.
All right. And we've seen the recommendation there is that she amends the guidance. And I'd just like to see it your help, please. On page 2, we have a summary of the position as it was and then what the plan was. The DHSE guidance for unpaid carers in England does not currently, so as at November, recommend that unpaid carers need to wear PPE when providing care. Unless advised to do so by a healthcare professional, in May 2020, PHE advised that carers who didn't live with the person they were caring for should wear PPE if providing personal care, and that co-resident carers should wear PPE if the cared for individual has COVID symptoms. So that was the position with the guidance. You were obviously aware that there were many millions of unpaid carers. Estimates vary between 5.5 million and I think about 7.7 million.
Well, it all depends how you define it. So yes.
Quite. And it's obvious, isn't it, Mr. Hancock, that there was not going to be PPE necessarily for all 5 to 7 million unpaid carers providing personal care.
Well, that's a perfectly legitimate decision for an elected government to make PPE available for free to everybody if they wanted to, but there is a limit on the public purse.
No, quite. It's not a criticism. It's
No.
a fact here that if we wanted to provide PPE for those many millions of people providing unpaid care, it would obviously place significant demands on the availability of PPE.
Yes, and the cost to taxpayers,
Yeah,
yes.
all right. Can I look, please, at page 5 and paragraph 7? The data on unpaid carers, sorry, it's my fault, I just jumped to the paragraph above to give some context. The data on unpaid carers, including how many there are, the types of activities they do, and whether they are extra resident or co-resident, is limited. Does that accord with your understanding of the data available on unpaid carers?
Yes, I'd say it's not only that it's limited, it's also a definitional question. So I would have taken, if I'd had a piece of advice like this, our best estimate suggests there could be as many as 7.7 million. I would have said, well, what does that mean? What about an elderly couple where one of them is in slightly greater disrepair than the other? Does that count? You know, it's really hard to define what an unpaid carer is and isn't.
Understood, but did the lack of a definition in any way impede or hamper the pandemic response to unpaid carers?
The way that we handled this primarily was through the shielding, where there was a definition of the risk to an individual, and then that individual's carers would be brought into the programme, either directly or indirectly. But it does mean that the whole subject of policy around unpaid carers is complicated by these boundary definitional issues. Some people are obviously unpaid carers, and nobody would dispute it. Others, it's just, people caring for each other. What does that mean in a formal policy sense? It's quite hard to define.
No, so that was to ask the question again. Did the lack of definition, though, in your mind, hamper the way that you approach the pandemic response to unpaid carers?
Well, the word hamper has a pejorative sense.
Well, I don't mean it pejoratively.
No, but my answer isn't a yes/no, because it's not really a yes/no thing. It's not a legalistic thing. It's just a piece of context you have to take into account when making policy in this area.
All right. The paragraph says clearly providing all of these carers with PPE would be unfeasible from a stock, supply and distribution perspective.
Yes, and I would add taxpayer as well. I mean, we spent a lot of money, but there was still a consideration of the taxpayer.
Okay. And then the next paragraph says it's unclear how many unpaid carers would take up an offer of PPE.
Yeah.
Currently in Liverpool regularly provides approximately 8 unpaid carers with PPE out of an estimated 52,000. Now, I know you said that the Minister wouldn't necessarily bring this to your attention, but were you asked at all for any of your views about the feasibility or otherwise of providing PPE for unpaid carers?
It was an item that we discussed. I don't precisely remember when, but unpaid, essentially, in the continuum of concern, unpaid carers are there, but less concerned than those in hospital, for instance. And so there's of course it's a consideration, but I would say that mostly I left policy towards unpaid carers I delegated it largely to Helen.
All right. But that can come down, thank you. You did, in fact, though, if I can remind you, by reference to your statement, I think you agreed to a proposal of a trial of free PPE for unpaid carers in November 2020. And in fact, in due course, then you approved a national rollout in January 2021.
Right.
Can you help us with why it was you agreed both the trial and, in due course, the national rollout?
I imagine because they were proposed to me with Helen's support, and I backed her judgment.
It may be suggested to you that the trial in November and the rollout in January 2021, to some, might look that unpaid carers are an afterthought, given that there was PPE provided to both care homes and the domiciliary care sector before that. Are you able to help with whether there was an afterthought here to unpaid care?
No. The word afterthought, which you've used a few times, is a rhetorical device to imply there was less consideration given, which is false and wrong. However, the context means that the acuity of concern was less by the nature of the group. That is an appropriate and reasonable position to take when you've got to deal with a huge number of things, and you therefore have to prioritise.
From your perspective, was there anything else you think now, upon reflection, you could have done earlier in the pandemic to provide additional support to unpaid carers?
I'm sure it's worthy of consideration. It's not an area that I was particularly close to. And I'm sure it's a question worth asking Helen, and I'm sure she'd come up with some sensible suggestions. It's just not something I'm particularly close to.
All right. Fair enough. Finally, on the topic of PPE, I said earlier this morning that you were in favour of all health and social care facilities keeping a PPE supply themselves for use in an emergency.
Yeah.
Can I ask you, how practical do you consider that to be for perhaps smaller care homes with less buying power, less space, limited shelf life of PPE?
Well, if they're smaller, they need less PPE in their stockpile. So the stockpile will be proportionate. You wouldn't have the same size for a big care home as a small one. Everybody's got a cupboard. And so it's totally reasonable to require a degree of PPE, say a month's supply You can pull any time period out of the hat, but a month would seem reasonable. That would take, in a small care home, that would take you would need obviously a storage facility for that, but it would be relatively modest. But the impact of it will be really great because it will give you a month to sort out all these problems that, it took us more than that to really get the system going.
What about domiciliary care? Would you make the same recommendation that providers of domiciliary care have their own supply of PPE?
Yes.
I presume not, though, for the reasons you just alluded to. You wouldn't be in a position to make a recommendation about that in relation to unpaid care.
No, I think unpaid care is different in its nature.
All right, understood.
And also, there's no levers, there's no contract, there's no, you can make a recommendation, but you couldn't enforce it in any way.
No. All right. A topic that you have also referred to this morning was that of visiting restrictions.
Yes.
And can I come back to that, please, just to get your overall views? Clearly, there is the protection of the residents versus the impact on them and their loved ones. And you mentioned this morning trying to strike the best balance, to use your words, in this difficult area. Did you ever consider asking for studies to be done about the extent to which visitors brought in COVID-19 into care homes? Yes,
that was part of the understanding, and I think you put it well earlier when you said broadly that the disease got into care homes through residents, visitors, and staff. I mean, essentially through people. That's how the disease spread.
Yeah. You are aware of the real upset, and you've mentioned it yourself a couple of times in evidence, that the visiting restrictions caused on a number of people who couldn't be with their loved ones when they died.
Yeah, of course.
No, it's not a criticism.
No,
Just
I don't
laying
take
the
it as a
foundation.
criticism. I just think it's awful. I mean, some of the things that people went through were truly ghastly, and it was an awful virus.
Yeah. I wanted just to pick up on one contributor to Every Story Matters, who said, perhaps not in the context of elderly people or those with dementia, but a loved one of a resident in a care home said this: "My son has severe autism and learning difficulties, has no speech and limited understanding. He was in a residential care home. I was unable to visit him for 24 weeks. We couldn't visit through a window or FaceTime, as he would not understand, and so became upset. It was a choice between keeping him calm or upsetting us all by seeing him through a window."
Yeah.
So clearly a number of people impacted in different ways.
Yeah.
5 years on, do you think it had to be either no visitors or allowing visitors? Did it have to be either or?
Well, that is a very, very good question. I'm glad you brought that example up because the care home question often ends up considering older age care homes more because actually for those of working age or people like the example that you've raised, the impact of visiting would be lower because the impact of the virus would be lower, and so that sort of consideration should be taken into account. We got to a position over time that was more nuanced. For instance, when vaccinations were rolled out, having a difference between those who'd been vaccinated and those who hadn't. When PPE was more widely available, allowing visiting with PPE. For instance, with hindsight, we know that COVID-19 spreads much less outdoors. Yeah. So visiting outdoors and at a distance would be safer than visiting indoors. So the more nuance and consideration you can bring into this, the better. So it isn't just a binary of no. Visiting or not visiting. It's how to do the least risky visiting. Like visiting and seeing people through a window, is very low risk, for instance, but obviously, as this example shows, doesn't work in all cases.
No. Do I take it that had there been enough PPE, that might have enabled some visiting to take place sooner than it did?
Well, it took some time to know how the disease spread.
Yes.
So, as visiting restrictions were lifted, then at that point, PPE was more widely available. And as you saw in the discussion that we had when we required face masks in hospital settings, one suggestion from one of my advisors, it was to have the PPE available when visiting restrictions were eased. So this is, in fact, an area of work, again, a bit like so many others, that consideration and thought should be put into it now so that more nuanced versions of policy can be put in place rather than having to invent it on the fly.
Yeah. And do I take it that if there'd been enough testing, that might have enabled at least some visiting?
Yes, and in fact, I think once testing was available to the general public, that was used as a, if you have a negative test, then visiting is more highly recommended. Again, you've got to have policy, and then sometimes policy isn't rolled out on the ground exactly as intended, not least because of the issues of accountability and authority that we talked about just before the break. So all of these things should be considered, yes.
All right. Can I just would like to ask you about one document that impinges on visiting restrictions, indeed the lifting of them. Can I ask to have up on screen, please, 327939_1. This is a submission that went to both you and the Minister in July of 2020. There was a proposal to publish updated guidance on visiting policy, and clearly it says there in the timing it was urgent. Visits remain a source of concern for many families and friends of care home residents, and they were keen to publish the guidance as soon as possible. And can I just look at the rationale for change with you, please, Mr. Hancock? Clearly, as we all acknowledge, there was making changes involves an increased risk of transmission. It must be balanced against the significant impact on the care home residents from being isolated. ONS data, as at the 3rd of July, shows that between March the 2nd and June the 12th of 2020, only 29% of deaths in care home residents were COVID-related. The deterioration of the physical and mental health of vulnerable people is likely to have been impacted by loneliness. One only needs to look at the final line, reference there to carers, representatives of residents who are, to quote, fading away. Over the page, you received, or annexed to it, I should say, was some sage advice that highlighted, as at July, there was medium evidence to suggest that visits of short duration, where appropriate social distancing and infection control measures are adhered to, are likely to pose a lower risk to residents than the risk of infection by care home staff. And then there was good evidence about the benefits of the residents seeing their visitors and their loved ones, and the detrimental impact on them of not having visitors for an extended period. And in due course, you were content for the guidance to be published in July. When we move forward to the winter of 2020 into 2021 and rising transmission rates again, you say in your statement that you took a hard line on loosening visiting restrictions. Can you just explain to everyone, please, why it was you considered in the winter of 2020 into 21 that hard line was required?
Because transmission rates were high and even higher than they had been in the first wave. Certainly measured rates were higher than in the first wave. And if you look at the analysis of who had COVID, it's highly likely that the real world rates of COVID were higher in the second wave, and therefore visiting was a significant risk again in a way that it hadn't been by July. In the middle of July 2020, the number of infections measured was only in the hundreds, as opposed to the tens of thousands by December 2020. So that's the reason. But I'd just say that on the previous piece of advice that you've showed, that shows the degree of thought and consideration that went into this question.
I don't think anyone's suggesting that there wasn't a degree, and there's no easy answer here.
Exactly, yeah.
But what I did want to come to ultimately, though, was your reflections on what we should do in the event of a future pandemic vis-à-vis visiting restrictions, when perhaps there isn't testing and there isn't a mass of PPE available. Would you still propose and advocate for an outright ban at the outset?
Well, I'd propose having a testing system that could be expanded quickly and having stockpiles of PPE that could be picked. So let's try to avoid being in that position in the first place next time round, please. But taking the question at face value, visiting restrictions are a reasonable measure. The more that you can introduce nuance into them, the better, taking into account the infection risk and the impact of not having visiting, exactly as this piece of advice did. Technology is probably now more ubiquitous than it was, and people, especially older people, might be more used to using it. And that helps relieve some of the lack of connection and the loneliness. But of course, it's not the same as face-to-face, and face-to-face isn't the same as physical touch. We all know that. I think it would be a very useful piece of work to think through in advance what is the best way to have the least worse outcome in this space.
You mentioned there testing. There's just one aspect of testing I'd like to ask you about, please, and it's testing for domiciliary care workers. Obviously, there was some access in April 2020 for symptomatic testing of domiciliary care workers, but in fact, asymptomatic testing for domiciliary carers was not introduced until November 2020, and in fact may have been not rolled out until January 2021. Can you help with why asymptomatic testing of domiciliary care workers was not rolled out until November 2020?
Well, this was about the access to tests, so it's not quite right exactly the way you put it, because of course asymptomatic testing was available to the general public by then, and so domiciliary care workers would have had access to tests just because they're members of the general public should they have wanted to. And therefore, I don't think the problem is quite as acute as set out. I can't remember the exact timescales around then of when the huge quantities of lateral flow tests became available, but that was essentially the breaking open of testing from a controlled to a widely dispersed issue, if you like, and that was in the autumn of 2020, wasn't it, when we got the first mass hundreds of millions of lateral flows through, and made the whole issue easier.
New topic, please. And I'd like to ask you about changes to the regulatory inspection regime.
Right.
Did you agree with the decision to suspend routine regulatory inspections?
Yes.
How were you assured of the safety and quality of care homes in the absence of those inspections?
I thought two things on that. The first is that whistleblowing was still possible in the worst extremes, and the second is that it was a necessary short-term measure given everything else that was going on and the risk of bringing COVID into care homes through inspections, but also that many inspectors are themselves medically trained and were needed on the front line.
In your statement, you said, I supported the CQC's decision to suspend because I wanted hospital and healthcare workers' primary focus to be treating patients rather than complying with inspection requirements, and to free up inspectors' work to work directly on the front line.
Yeah.
The reference there to them, rather than complying with inspection requirements, may to some sound dismissive of the importance of inspections. Why did you phrase it in that way, Mr. Hancock?
So I'm a supporter of inspections, but the reason I phrased it in that way is that these were extraordinary times. Care settings and hospitals were doing unusual and extraordinary things, and sometimes one of the reasonable criticisms of most inspection regimes, including the CQC's, is that they can get box ticky, and what the last thing you want is somebody making a decision based on a worry about a future imminent CQC box ticking exercise when there is life-saving work to be done. It comes back to my overall, the way that I led the health system was to presume that everybody would be doing their level